the pediatric hospital within the Rambam Healthcare campus. So when we speak about coronary synostosis, like in any subject in medicine or in neurosurgery, we have to ask ourselves a few questions. First of all, do we really need to operate coronary synostosis? It's not the regular issue in neurosurgery. It's not a life-saving procedure. It's mainly cosmetic and some functional procedure. So do we really need to operate? And who is a good candidate for surgery? And how to diagnose the coronary synostosis, and actually how to treat and how to follow. So just a reminder about the skull and the sutures. The sutures a suture is actually a fibrous joint connecting the skull bones, and the suture is open as long as the brain is developing and pushes the skull, and eventually the last closure of the suture is around the age of 18, although the skull volume reaches its 9 to 19th% around the age of 6 years. And the first definition of coronary synostosis was done by Summering in 1791, which described the skull deformation due to premature closure of the skull suture. So just a reminder that the sutures, not connecting only the skulls of the calvaria, but also the bones of the skull base, including the frontoetmoidal, the temporo-occipital, and so on. This is important because it's another reason to open the coronary synostosis when sometimes there is also narrowing of the skull base. When we speak about coronary synostosis, there are actually 3 types of coronary synostosis. The type that I'm not going to speak about is the secondary coronary synostosis that usually happens due to some metabolic changes or metabolic abnormalities, hypothyroidism or hyperthyroidism, some hereditary diseases, anemia, and so on. I will speak mainly about the primary non-syndromatic synostosis, and I will add a few words about syndromatic synostosis. So if a regular, normal skull shape is symmetrical and a round shape, according to the different types of synostosis, we see different shapes of the head, different deformities, but we always have to remember that currently in this era, we see a lot of positional plagiocephaly, since the recommendation is to put the children after birth on their head in order to avoid sudden death. We see that children sometimes develop change or asymmetry of the skull, but all the sutures are open. The treatment of this plagiocephaly is mainly behavioral, but for the true synostosis, there is a true closure of the suture, and then we see abnormal and asymmetrical development of the skull and of the brain. So how to diagnose the synostosis? So in the past, we used to do plain X-ray. We did a lot of CT with 3D reconstruction in order to see the closed suture and the abnormality of the skull. Sometimes we can use ultrasound to see the open or the closed suture, and nowadays there is the protocol of black bone MRI. But actually, the diagnosis of coronary synostosis is clinically. For an experienced neurosurgeon, a pediatric neurosurgeon, it takes maybe 10 seconds to diagnose the synostosis and the type of diagnosis. And then we can avoid all the troubles, all the problems that can be caused by the imaging studies. Plain X-ray has no role. Ultrasound needs a very experienced radiologist. CT has the risk of radiation. And black bone MRI, although it's a short protocol of MRI, still the child needs to be anesthetized and with the complication of this MRI. So actually the diagnosis in most of the coronary synostosis is a clinical diagnosis. So why do we need to operate coronary synostosis? So first of all, there is a cosmetic changes. We can see here this child. Well, I just want to say that all the children that you will see here, the families agreed to show their pictures. So cosmetic changes, okay, mainly in scaphocephaly. You can see a child with trigonocephaly. You can see a premature closure of the metopic suture and the trigon shape of the head, and you can appreciate the cosmetic problems or the cosmetic issue in this child. Many times we see hypothyroidism and strabismus, like in this child, again with trigonocephaly, hypothyroidism, a significant hypothyroidism. This child has strabismus because of she has a coronal, left frontal coronal plagocephaly, and you need to know that the abnormal side is the left side when the orbit is going backwards, causing the harlequin shape of the orbit. Many times we see, because of the formation of the nose and the nasion, as you can see here, we see narrowing of the upper airways, and many children actually snore during night time especially. They can, very difficult, they can breathe through their nose. As you can see in this child who had with trigonocephaly. Sometimes we see increased ICP, mainly in syndromatic patients. This child with a Cruzon syndrome, hereditary Cruzon syndrome, she arrived our hospital with headaches, vomiting, and actually she had papilledema. So when we see the patient and we speak to the parents, what do we need to tell to the parents? So first of all, we have to describe the situation. We have to tell them why we want to operate the child. We have to describe the skin cut that we perform, which is a zigzag skin cut from ear to ear. When longitudinal cut, when we perform correction of scaphocephaly, we perform around 10 to 12 centimeters of skin cut. We tell them that after the surgery, the child will go to the ICU. They may receive blood. Actually, most of our patients, nearly 100% of the patients, receive blood during the surgery. Sometimes they need blood after the surgery. We put a subdermal drain or subcutaneous drain for 3 days. They are going to experience lots of pain. They will going to get analgesics, and for those children that are still nursing, we definitely recommend to keep on with the nursing, because the mother's milk is the best opium that the child can get, and of course it helps us with the infectious issues. So we encourage breastfeeding. They may have fever after the surgery, so they will be on antibiotics, and they will actually have swollen eyes in a way that they won't be able to see. Like you can see, you can appreciate in these children that had the swollen eyes, they cannot open the eyes, which may cause for 3 days, which may cause actually they suffer from this inability to open the eyes and communicate with their parents. And the most important thing when you start the surgery, before you start the surgery, during the timeout, you have to make sure that these children have 2 large IV lines and arterial line, because the major complication of coronary synostosis surgery is blood loss. So they may lose sometimes up to all their volume. So we make sure that they are hemodynamically well monitored and well treated. They will have NG tube. We many times give them tranexamic acid, hexacapron, in order to reduce the blood loss. We prepare blood products. Most of the time we operate them in the supine position, sometimes in the prone position, and make sure that everything is well positioned. So the principle of surgery is to open, first of all, to open the suture. Many times we perform canthal advancements, and we'll see some examples. We have to reconstruct the skull. Sometimes we need to expand the skull when there is an increased intracranial pressure, and when we suspect of increased intracranial pressure, and in order to achieve brain modeling. When the brain will develop symmetrically during time after the surgery. And there is the question if we should do it open or endoscopic, and with regards to new techniques, and endoscopic is a new technique to perform coronal synostosis repair. The main problem with the endoscopic procedure is the helmet. Although it's some kind of fashion, currently mainly in the North America, there is a fashion to put helmet, both for positional plagiocephaly or for true coronal synostosis after endoscopic procedure. There are many issues with the helmet. The loss of the ability to reduce the temperature of the brain, okay? So the brain is being heated a little bit. These children need to wear a helmet 23 hours a day, which cause them they suffer from this helmet. They may have the cubitus ulcer, and when we look at one-time procedure versus long time of helmet, definitely it would be recommended to do one procedure. I always tell the parents, try to put a bicycle helmet on your head for 23 hours a day for 5 to 6 months, and come back and tell me that you're happy with this, and we'll do it to your child as well. So we prefer the open procedure. This is an example of scaphocephaly, a longitudinal skin cut, exposing the closed suture, open the closed suture in a width of 5 to 7 centimeters, and then we do cuts. If you can see cuts in on the sides, and we take off the posterior triangle. This is the lambdoid suture over here. We take off a triangle of the bone from both sides. Okay, we create a green stick fracture in these barrel stave cuts, and then we let the patient, and we put a drain, we close everything together, and then our recommendation is to put the head the child on the head for 3 months. And then actually this position push the skull to the sides, and these children have a great cosmetic result. We'll see it afterwards, the cosmetic results. This is a child with plagiocephaly, coronal plagiocephaly on the left side. You can see the closed suture and the open suture on the right side. This is the healthy side. Then we open the skull. We open the skull above the orbital bar. We take the orbital bar. Now we need to expand it and to change the structure in a way that we can, the abnormal orbit that was pushed backwards, we perform canthal advancement, so we can put it in a normal shape. You can see the eyeballs from the inside. This is the dura. Cuts in the parietal bone when you open the cuts in a green stick fashion, and then we close everything together. This is some shapes that we do in the bone in order to enable the brain to push the skull in a way that it will build itself. So we call it remodeling of the skull according to the brain development, although most of these cuts are closed in 3 to 6 months. The skull is usually complete. Cranial expansion in children, in older children with elevated ICP. This is our technique. The most important thing is to make an expansion of the skull in a way that there is a gap between the dura and the bone of 1 to 1.5 centimeter, and to detach the superior sagittal sinus. This is the way that we do it. As you see, the shape of the skull that we removed in a way that we can put it back in a distant fashion. This is how we put it back, and let the the brain to expand. Some syndromatic patient. This is a child with Preacher-Collins syndrome. As you can see, narrowing of the orbits and the face. And this child had also trigonocephaly. So he had a premature closure of the metopic suture. We took him to the OR with catheter advancement and expanding the orbital bar. This is how it looks after the surgery, and we have to remember that we need to reshape the eyes, the mid-face, and the mandible, but we do it a few years later. He was operated initially for this chronic synostosis at the age of 10 months. This is a child with Apert syndrome that we also had ICP issues, and you can see that he has an elevated ICP. You can see these finger trips or bitten Cooper sign or bitten Silver sign, the impression of the gyri on the skull itself. So we had to expand his skull. This is at the end of the surgery, and this is the what he looks like, how he looks like after the surgery. So complications of chronic synostosis, we speak about 1% of mortality. Most of the mortality cases are due to blood loss and air emboli, which is rare but can happen, because when the skull of a child has many emissary veins and the skull itself is bleeding, so air can go through these veins into the lungs, so pulmonary embolism, air embolism, bleeding. Some will have respiratory failure, but it's already in anesthesiology issues. Dural tear can happen many times, so we close the dura immediately when we cause the tear in order to prevent them to go into to the subdural space and to the subarachnoid space. And sometimes we perform another surgery because the shape is not good enough, or there is a recurrence of the abnormal shape. And I cannot give a talk without speaking about the October 7th tragedy in Israel. This is the Bivas family, happy family, that was kidnapped to Gaza Strip. You can see this one of the kidnappers with his shirt with blood. You can see many Palestinians, terrorists, kidnapping these children. You can appreciate the face of this mother with the horror on her face, and we hopefully will see him back soon. Thank you again for having me here. I really enjoy the city, and I really enjoy to be in India. Thank you again. Any questions?
Very nice talk. Thank you very much. Anybody wants to ask a question on this topic, craniostenosis? Not many people do it. How many of you do it, craniostenosis? So any question, Dr. Sahu? Manas? Dr. Misra? Anybody?
How to manage means many of them have blood loss in children. How often the ICU stay has been more because of the blood transfusion and related complications?
How many often do we see complications due to blood transfusion?
Yes.
Well, to be honest, I haven't seen a complication from blood transfusion of any blood transfusion in the last decade, I think. By the way, I didn't mention, but this is my team. This is Dr. Omri Amodi, who is helping me in the surgery, and this is my team in pediatric neurosurgery.
Yeah. Thank you. We recently published about 500 cases of craniosynostosis. All of them received blood. 0 complications. I mean, some of them have a reaction, we stop it, but nothing on the lung, no viruses, no anaphylactic shocks, nothing. It's published.
I have operated maybe more than 500 cases. We started in 1986. There will be dural tear. There will be blood loss. Whether they give blood transfusion or not. But I don't keep anybody in ICU because children are scared, and we don't have a dedicated neonatal or an infant ICU. So most of my patients in recovery room go. And regarding the nasogastric tube, I don't put nasogastric tube because that will make them more uncomfortable and restless. It's painful. So we don't put nasogastric tube. Only if you are in frontoorbital advancement, they require blood transfusion. Because then it's a major surgery. If you don't just strip craniotomy or something like that, nothing happens. Unilateral plagiocephaly doesn't require blood. So I think you have to be very careful what type of cannulations you're doing. Actually, once I talked to, before Swami, I talked to Dr. Tessier, who had done more than 3,000 cases. He said he would follow this patient for 15 years, from age of 3 months to 17 years. Most of them, they require 4 to 5 operations. Because this is cosmetic surgery, what is accepted to a family at 3 months will not accept 10 years, not 15 years, 20 years. So many of these patients, I was telling Swami, that I talked to once to Dr. Tessier. He said average 3 operations are done for these children. Your slides have come. So anything, anybody want to comment? The slides are not ready. Ready? Where are the slides? Moving.
Laser?
Okay.
Any laser? It's okay. I can manage. Thank you. Thank you very much. Pleasure to be here. I have 2 talks in a row, so what I would like to do is use about 5-6 minutes for a general introduction, and then about 15 minutes to each one of the talks. So I would like to start by the talk about pediatric craniopharyngioma. I'm representing here not only my center, my country, but also the ISPN, the International Society of Pediatric Neurosurgery. Remember, it's a source of friendship, of family. It's truly global. It's an educational source. We're building now the library and enhancing the guide. We have stipends for new members, especially for residents, and membership is free. The next meeting will be in Toronto in October. So a little bit about India and Israel. This is Moody and Bibi, and at that time, a few years ago, I was going to visit 2 places in India, and I put my little country, Israel, here. These were the places that I visited at that time and now. And what I did was to superimpose Israel on top of the mega continent called India. And if you compare the surface area between Israel and India, the numbers are stunning. This is, by the way, Switzerland, also put on top of India. So if you compare the birth rate in India, over 18 million children a year, in Israel, 170,000, this is a rate of more than 100 more children born in India compared to Israel. So with 18 million in India and over 45 million born in Africa, there is actually such a big inequality in surgical care around the world, and we produced this cover for child's nervous systems showing that only about estimated 10% of the global population of children around the world are receiving proper care. This is the Tel Aviv Medical Center, this is the Dana Children's Hospital, this is where our clinic is. We're an international department. Please come and visit us in Tel Aviv. These are 2 residents from Ukraine that just finished with us. This is Harshal Agrawal from Mumbai, who is with us currently. This is Olga from Russia, who will come in July. And this is Carla Riqueta from Milano, who is now in Cincinnati and then will come back to us. Why children? Well, children have a different presentation, pathology, philosophy, different treatments, and different technical aspects. They need to be in a children's hospital, and you need to address the whole tribe. Children are strong. They're strong emotionally and biologically. And the adult experience that we have, for example, with gliomas is not relevant for children with all these aspects, molecular, biological, response to treatment, and long-term effect. Look at this single slide comparing high-grade gliomas between children in the upper row and adults in the lower row, just for these 3 markers, EGFR, P10, P53, tumors that look the same on H&E staining behave exactly the opposite when you look into the molecules. In adults, low-grade gliomas always undergo malignant transformation. In children, malignant transformation is exceedingly rare. Again, the same tumor under H&E behaves biologically exactly in opposite direction. Response to treatment, this is the famous Stupp study showing that concomitant temozolomide does make a difference, a small difference, but a difference in adults. And in children, it does make a damn difference if you look at high-grade gliomas. So all these aspects are different. The other thing which is different, we recently summarized over 300 pediatric brain tumors. 4 out of 5 will be alive 10 years later. This is enormous, enormous amount of traffic because we continue to follow them yearly, and we have over 2,000 children that we are following with pediatric brain tumors with additional 200 per year. Huge traffic. You need to give them a place where they can go and call at each time. Craniopharyngiomas. This is a paper that we just published in Current Oncology Reports. I actually asked our host to spread this paper. I sent you the PDF. I don't know if you noticed it. So anything I say is summarized in this paper that we wrote together with the esteemed group in St. Jude, Tom Murch and Frederick Group. This talk will also be in the ISBN library, which will open its gates in the coming summer. It's a mega educational project of the ISBN. Well, this is Fred Epstein, my mentor, and Fred did 31 years ago, he did a focused meeting on craniopharyngioma called Craniopharyngioma, the Answer. Actually, there are no answers, there are more questions today, maybe some answers. This is a slide that I adopted from Rick Boop, my friend. Tumors I like and tumors I hate in pediatric neurosurgery. So we all love the JPAs. Even the germinomas are fantastic because we have effective treatment. The low-grade gliomas, the JPAs in the chiasm a little less good, medulloblastoma less good, PNET less good, ependymomas give us a lot of trouble. And as you can see, craniopharyngiomas are quite down in the list. Next are the mixed germ cells, and of course the glioblastomas and the ATRTs. So why don't we like craniopharyngiomas so much? The reason is that there are many choices. And having choices complicates our practice very much. What we have done lately, we've been shifting the decision to the shoulders of the family. This is called, it has a name, shared decision-making model. I'm not sure I like this model, but I'm a little bit old-fashioned. So Harvey Cushing said one of the most baffling problems to the neurosurgeon. He was right. It's benign, but it is very resistant. It can come back. Today I will talk about pediatric craniopharyngiomas and not about the adult craniopharyngiomas. High ICP, when there is hydrocephalus, compression of the optic apparatus, and of course of the neuroendocrinological apparatus causing all sorts of endocrinopathies. Diagnosis by MRI. CT has a role because you see the calcification. So if you see a cellular, supercellular tumor that is cystic with calcification, it will be a craniopharyngioma. What are the measures of success? Before we used to look at mortality and morbidity, then at Glasgow outcome scale. Lately, Karnofsky is important, but in the new millennium, we really look about quality of life, about neurocognitive, about neuroendocrine, about ophthalmological, and of course about the long-term results that we have. So it all started with the cowboys. The cowboys. This is a paper from our teacher, Ghazi Yasogil, and even Ghazi appreciated that the larger the tumor is, the greater will be the morbidity. This is from Harold Hoffman, a pioneer in craniopharyngioma surgery. 50 cases of craniopharyngioma. In his paper, he admitted that about a third came back after GTR. And look at that. 12 patients are able to function reasonably well. Would you be able to sell that to parents, that 1 in 4 can function reasonably well? And this is another important group, also my mentor, Jeffrey Wissoff, also admitting that the recurrence rate is significant, and many, many other papers of people claiming that they can do craniopharyngiomas, and everybody is fantastic. Then came the acknowledgement of hypothalamic involvement, especially the posterior hypothalamus. And then came the classification by Puget, 0, no hypothalamic involvement, 1, hypothalamic displacement, and 2, clear hypothalamic invasion. And you can see on top is 0, mainly in the sella. 1 is in the middle row, pushing the flow of the third ventricle up, and in the lower row, Puget 2, with clear involvement of the hypothalamus. In parallel came the notion and the understanding that radiotherapy is indeed effective for craniopharyngiomas. This is a study from the CHOP group from Philadelphia, Leslie Sutton, who found no difference between GTR and STR combined with radiotherapy. Another paper from St. Jude, who have become the leaders in craniopharyngioma research with the same result. And if you can look at the upper right corner, you see the Kaplan-Meier complaining GTR and STR plus radiotherapy. It looks very much the same. And then came the protons. The protons make a difference. The protons allow us to irradiate the craniopharyngioma or any deep-seated tumor, especially in young children with less exposure of the brain. This is a paper just published now. Amazing, amazing results. Progression-free survival, 93% for minimal invasive surgery combined with proton therapy. This is from the St. Jude group. And if you compare the reading score and the mass score between protons and photons, this graph means everything. I have converted myself, and we send all the children with cranios and small children with ependymomas, we send them for proton therapy. The other group which made a whole lot of difference is the, in addition to Tom Merchant's and Rick Boop in St. Jude, is the group from Germany. We'll talk about them. So is this really a good result? Look at this sweet kid becoming very fat, and this one becoming, this is not chubby, cute children. These are children with obesity, and sometimes with modern obesity. It's not a good result. So many times what you see is that the BMI increases very significantly, that the child who was a good student is struggling to make B's and C's, personality change, emotional aspects, outbursts, and memory problems. So this group in Germany, led by Hermann Müller, the advantage in Germany is that they centralized all the kids that were operated in Germany, and they could follow 100% of them. Again, stressing that the posterior hypothalamus messing around is not a good idea. Another paper from this group. Then came the era of intracystic injection, either of particles, option 1, bleomycin, a sclerotic agent, option 2, and interferon. There were a few promising results, but this is a paper, I was part of it, that looked at a large number of children who received intracystic therapy, and I summarize for you, if anything, it's a temporary measure. I'm not sure if it does anything. And then the issue of the BRAF treatment is relevant only for adults. It is not relevant for children. So to finalize, I want to show you 2 cases that were operated upon in the same week in my department. They were in the same room. A tale of 2 patients. Patient number 1, craniopharyngioma 1. Remember, an 8-year-old, endocrine normal, vision normal, a little bit low IGF-1, no diabetes insipidus. Craniopharyngioma 2, a 12-year-old with weight gain, low height and headache, vomiting, normal endocrine, right temporal field loss. That's the only thing he had. This is craniopharyngioma 1. You see this cellular, supracellular, partially cystic tumor. You see on the CT scan the fleck of calcium. You see the coronal view on the right-hand side. And this is craniopharyngioma 2, categorized as Puget 2. It's solid, cystic, and causing a little bit of hydrocephalus. Craniopharyngioma 1 was operated from below, transnasal approach. From below, it went well. It was an STR because we left the membrane on the upper top of the tumor approaching the hypothalamus. No intraoperative complications. Craniopharyngioma 2, was operated from above, just endoscopy and putting a drain with an Ommaya into the cyst. This is the post-op of the first one. You see it looks wonderful, but we know there is tumor. That white margin is tumor. And you see the little fleck of calcium is still there on the CT scan and a coronal view. And this is craniopharyngioma 2. You see the catheter deflating the cyst. What happened? One stayed 5 days, one stayed 13 days in the hospital. To summarize, both of them were sent for protons. Both of them are stable 4.5 years after the administration of proton therapy. One has panhypopituitarism, the other one is intact. This is just the pictures showing. Oh, I'm shortening, so I want to summarize saying what is acceptable morbidity? Personality change is probably not acceptable. Emotional outbursts, not acceptable. Panhypopituitarism can be acceptable in Western countries where treatment can be delivered. DI with preserved thirst mechanism can be acceptable, but DI without preserved thirst mechanism is unacceptable. And morbid obesity is not acceptable. So I wish Jesus could help us to make the right decisions, and especially with craniopharyngioma, very difficult. It's a teamwork. Everything is a teamwork. And I will not go in this lecture about comparing pediatric to adult craniopharyngiomas, but they are somewhat different with different treatment philosophies. Thank you very much.
We'll take some questions now. Anybody? Yes.
Very nice, Shlomi. I really enjoyed it. And they encapsulated the whole pediatric craniopharyngioma, which is something which we struggle still today. And unlike a place where you work as a pure pediatric neurosurgeon, I think in India, there may be one or two. All your colleague pediatric neurosurgeons are not real pediatric neurosurgeons. They are neurosurgeons with an interest in pediatric neurosurgery, except probably maybe I can count in my hand, right? So the problem is, first, number one, hypothalamic classification. I am so confused. I have 40 years experience with my best neuroradiologist, very highly qualified, trained.
I'm not the only one hearing the hits in the head, right, in the ceiling. I'm not the only one. I just wanted to make sure it's not my phobia.
In spite of that, sometimes it's impossible to have that classification preoperatively. And it's a fact, number one. Number two, what is your follow-up with the proton? How long is the follow-up?
With what, with protons?
Proton.
Yeah.
So
Thank you.
the question
Thank you.
is...
It's good questions, all of them. They're good questions. First...
I haven't finished.
Yes, sorry.
So if you have a small residual tumor and you have some other form of radiosurgery as opposed to proton, because we have one proton beam as of now. I think there is one more in Bombay which is just becoming operational. I don't know if there is anyone coming up now, but it's already in Tata in Mumbai, which is there before actually the Chennai one, but it's not operational because of government some regulations or so. So, you know, to go back with this, which is very, very impressive data, that you have to send everybody to proton, is something which is not possible. It's just not possible. And not in India, in major part of the world, it's not possible. So we have to be very clear about the data which you are showing. I know Rick Book's data. I mean, we have gone together many. So I have always this problem of accepting a data which is so many years, which is a tumor which is lifelong. I mean, I have a talk which I say, you treat one craniopharyngeal, you treat for life, the child and family. So I would like to have these two answers from you.
Yeah, it's all good comments and questions. The easiest answer is regarding radiotherapy. You don't have availability of protons, do photons. My bias and most of the Western world would be to do full fractionation. Okay, and we have a lecture about single therapy that we will hear soon, but I would do photons, I would do IMRT, I would do full fractionation, 6 weeks, every week get a scan to make sure that you can limit a little bit the boundaries of the tumor. It's very, very reasonable to give photons as long as your person delivering radiation is an expert, right? That's it. If I would have to predict the future in 10 years from now, you will have a lot of proton centers. I would rather have a good photon than a bad protons. The follow-up with protons in St. Jude is reaching almost 20 years. The pencil beam has come in relatively late, and that specific comparison that was published now in Lancet Oncology is 5 years. 5 years the minimum. 5 years minimum, but many patients are up to 10 years. There is recurrences. There is. You will always have recurrences with craniopharyngioma, but the number is very small if you do it very carefully. And the other things, I mean, it's a whole world. It's difficult to answer. Sorry.
Guardian. Classification, hypothalamus.
Hypothalamus. How confident are you whether the hypothalamus is shifted or involved?
No. I would not go into a Puget 2. If you go into Puget 2, you're gonna. Is this? Am I answering your question?
No. That's not my question. My question is, how confident are you about the classification that this is Paget 1 or this is Paget 2 from imaging what you have now? Do you understand my question?
No, sorry.
From imaging, can you tell hypothalamus involved?
Are you sure that it is Paget 2 or Paget 1 before the operation?
No.
Look, when you operate, and I do a lot of endoscopy, you see, even if it's a cyst, it is invasive. It is invasive to the tissue. Most of the cyst wall will not peel nicely. Some of the cyst walls may peel nicely, either on an endoscope or in an open approach, but a lot will be invaded. The one thing we have learned, we call it, the Harold Hoffman approach. He would go through the lamina terminalis and do blind movements in the third ventricle. The slides of the MRI looked fantastic, but the clinical results were not good. And after GTR, at least 50%, if you wait long enough, will have a recurrence. When a cranial comes back, doing another GTR is almost impossible. Almost. Maybe for those restricted to the cell. The dilemma. Sorry.
I think we wrote a paper that even with gross total remove it, they go and have islets of small tumors in the hypothalamus, which cannot be seen in MRI or MR spectroscopy. That is how in one of the Deepak's paper we said, two types, adenomatous type and papillary type. Papillary type will go and infiltrate hypothalamus islands. So unless you take a normal biopsy, you will not know how far it has gone in infiltration. Second, I don't know how many of you have read Kobayashi paper. He gave gamma knife to them and followed for 10 to 15 years.
Which paper?
Kobayashi from Japan, Kobayashi. Mm-hmm. And he followed them for 10 years. 10 years recurrence-free period in craniopharyngioma after gamma knife was about 80%, which was very good result. It was about 10 years back. So if you go to 3 paper he wrote between 2005 and 2012, of course 10 years now, but that result was quite impressive. Thank you. Yes, can you have just, yes. I think we want this because there is common problem and there is no solution.
Yeah, regarding the follow-up, craniopharyngioma is a benign tumor, and like meningioma is an acoustic tumor. I think the importance of long-term follow-up is crucial. And when I say long-term, when they ask for how long I will do for life, because after doing for some of my patient radiation after 20 years, I start to see the recurrences in acoustic and also in craniopharyngioma. So it's very important to continue with the long-term follow-up.
Long-term follow-up, for sure.
Probably long-term follow-up. That's the message. Probably we are underestimating the impact of radiation, either photon or proton, compared to surgical removal or surgical decompression. Probably the impact is biologically is more pronounced, and I agree completely. It has to be fully fractionated, 27 or 30 fractions, not below that, because you need to preserve the optics and you need to preserve the hypothalamus. The study that you mentioned about that shows clearly the cognitive outcome of a pediatric population after photon versus proton, which was significantly significant in the proton, was not the same for the control, or for what we call the control rate or the probation-free survival. It was the same between photon and proton. That's why I agree, if you don't have a proton, go to photon. It's very important that the child will receive something. You cannot leave him without any extra, and this is my opinion, extra radiation. An option for follow-up after partial surgery is not reasonable nowadays.
Right. I did not mention it, just 1 second. The vasculopathies...
Why do you tell all are benign? Your all molecular marker are shown, Ki 67 and P53, lot of marker in craniopharyngioma. So, from external appearance, general histology, you cannot tell benign or malignant. That is how, after total excision, 50% will come back within 5 or 10 years. So, it is molecular marker who will tell that he is going to recur or not, to some extent, not that always. Yes?
Yeah, I just want to comment regarding the Puget classification. I don't care about the Puget classification anymore, because currently my doctrine is to, if it's a cystic lesion, put a drain in and then send to radiotherapy, either proton or fractionated photon therapy. And if it's a solid tumor, with a minimal biopsy, not minimal, but biopsy, maybe a limited resection, and then sent to radiotherapy. Even though it doesn't, in Puget 0, you can cause panhypopituitarism, which is very significant side effect and very low quality of life. And I see the patients, long-term follow-up. Some of my patients I'm following for maybe 15, 17 years, those who were treated by Hoffman many years ago, Israeli patients with craniopharyngioma, and have terrible quality of life. So I think that any solution, although it's a major problem without solution, but any solution is better than gross total resection in pediatric craniopharyngioma.
Craniopharyngioma is always like this. It's very
there
heated.
is no solution.
Everybody has a view.
Yeah, the longer you follow up,
it's a religion.
But the only thing which Dr. Mahapatra talked about, not only on Kobayashi, the Japanese group and the French group. The French, I'm sure you are aware of your pediatric French group. They have very large, and again the national data, and Maurice has talked about it, and they have very good results with gamma knife. So they have published it, and I'm sure you are aware of it. And not only Kobayashi, Ohata is much recent data, which has beautiful, in every single patient is followed up for, I think now he's now 30 years down or 40 years down the line, and all his patients are followed up. They're not lost to follow up. Multiple therapies, but they're very aggressive, more of adult, not pediatric, Ohata series, but there are pediatric. But I think Maurice Souk's series is mostly, the French group, is mostly gamma knife treatment.
I think gamma knife is a very good option for the recurrent craniopharyngioma. There is no point, because if you operate them, definitely you are not going to have radical surgery.
I have a lot of difficulty in gamma knife, because the things which are left is in the hypothalamus or near the chiasma. So gamma knife to me is not, though I have the gamma knife control, I don't like it. I like the fractionated radiation therapy.
Okay.
Okay, next up. Okay.
We move on.
All other discussion during the tea time.
May I have my second talk, please, about osteoporosis?
Every IS meeting
Yeah. Thank you. It's the right light. I'll try to make my next talk a little shorter. So this is really an educational talk about midline approaches to the posterior fossa. What are we talking about? We're talking about Chiari, about tumors in the posterior fossa. We're talking about pineals when you've got to go up sometimes, and we're talking about posterior fossa cyst, which is a whole world by itself. The preoperative considerations: how to treat hydrocephalus, if there is hydrocephalus, by a shunt, by an ETV, by an EVD. Do the EVD separately, do it in the same session of the surgery. This is something we have to think about. Do we need navigation? In most posterior fossa, there's no need for navigation. We use an ultrasound. Sometimes we do. Neuromonitoring for those associated with the brainstem. To give or not to give steroids, we usually give steroids with tumor. And in infants, you have to consider the issue of blood loss. Positioning, crucial. We like to do prone position. I almost stopped totally doing seating position. You see, this position is fantastic because it allows you to work in 4 hands. I find the assistant especially helpful in midline tumors in the fourth ventricle, and this, of course, the sitting position for those who like it. The last time I did it is about 5 years ago for a pineal located supracerebellar approach. For those who do it, for example, Majid Sami does it regularly for acoustics. Those who do it swear by it. I like the Sugita. Sugita has up to 6 pins. You can modify the pins. The head will never fall, and it has a retraction system. If you use the Mayfield, sometimes use the Mayfield together with the Doro system. We'll see some examples. You mark the patient before you drape the patient. So you mark the inion, you mark the transverse sinus, you mark your place for EVDs so you don't get confused when the patient is covered. This is the Doro. The Doro is very nice for little children, for infants, because you have an extra rest to the head in addition to the pins. The Sugita, as you can see on the right-hand side, has a beautiful retraction system. I love it. It's a Japanese system, and we swear by it. This is a device. We call it Tushy holding device. It is crucial. You put a tape across the ass of the patient so that in case you have venous bleeding, you can take the patient up without having an air emboli and without having the risk of the whole body sliding down. Tushy holding device. And of course the Doro, you can see examples here. It's a beautiful system, the Doro, not only for posterior fossa. When you pin the hand of infants, be careful. You can easily give an epidural hematoma. Look at kinking of the tube, how the tube is secured, not to have too much flexion. If you have too much flexion, the tube goes into the right bronchus. Take into account the flexion and check the breathing before you do a skin incision. Free abdomen as much as possible. Head above the heart. Flexion we discussed, especially in cases that you want to open the foramen magnum. Plan your angle. Opening of C1 is mostly, not necessarily, sometimes it is, especially in Chiari where you want to open the dura a little bit more down. The inion, where to do the cuts, how to mark the transverse sinus. Usually the cut goes all the way down to C2. You have veins in the posterior fossa. There is no easy posterior fossa approach. You have veins, and the veins are especially pronounced in infants. As you see in the right-hand side, the red square, you see an occipital vein going down. Sometimes the occipital veins will grow to the side, so even if you open the dura in a Y shape or U shape, you will get tremendous bleeding from between the two layers of the dura. Have a good helper when you do it. Reduce the pressure. It is nice if the hydrocephalus is controlled. You will have less pressure from veins, and always open the two halves of the dura leaves, otherwise you will not be able to suture or to put a clip. Open the muscles. Remember, whatever you open, you'll have to close. The fascia is your only watertight layer. Undermine the subcutis, make it wide so that you see the foramen magnum at least 2 centimeters to each side. Clean the bone. If you have bleedings from the bone, clean the bone and then put bone wax on top of it. Make sure you have the foramen magnum open, and then you do the holes. The holes we never do on the midline. We put on 2 sides of the midline as up as you think is necessary, and we combine the opening manually with a Carrison rather than with a drill. In the beginning of my career, I used to put another 2 holes close to the foramen magnum. Now we usually take the drill and bring it down to the foramen magnum. The veins. Crossing the midline, we talked about, using Carrison. Towards the foramen magnum, refrain from using high-speed drill. Towards the sinuses, be careful with the drills. Again, careful dissection of the atlanto-occipital membrane from the bone using the monopolar. And then widen the opening of the foramen magnum. I do it routinely for most tumors, especially medulloblastomas in the fourth ventricle. Some people are not so strict about opening the foramen magnum. I am. And then when you open the dura, open it safely from both sides and leave the midline for later. Dural bleeds can happen. If you have a dural bleed, pack it. Elevate the head. Get oriented, get ready, and then deal with it. You deal with it either with the bipolar, or with the suture, or with vascular clips. Foramen magnum we discussed already. Then after you open the dura, you open the cisterna magna, you release pressure, and you go into the tumor. C1 laminectomy only in selected cases. Be careful with exposing the sinus. If you want to go supracerebellar, or you have tumors that go all the way to the tentorium, expose half of the sinus. It will save you a lot of time. And then you come to the cerebellum. The picture in the middle and in the right side is a little bit of old school. We try to avoid putting fixed retractors and going with a midline opening in the vermis. It's probably associated more with cerebellar mutism. We usually do what we call dynamic retraction. You can do it especially if you have a good and experienced helper. And then what is called the telovelar approach. It also confuses a lot of people. If you're lost in finding the telovelar approach, just go a third in the height of the cerebellum, the folia horizontal, open the folia horizontally. You will get to the arachnoid that will lead you to the foramina of Flushka. Closure of the dura is very difficult. We usually use either Tacosil or gel foam, biological glue, whatever you prefer. There is no evidence that it helps. Closing the fascia and the skin is terribly important. We use by craniofix or by titanium plates the bone. Skin closure, I want to go back to it. Sometimes you're not able to close the fascia properly, especially on the upper side. So your subcutaneous and your skin closure is the last barrier for fluid, especially if the hypothalamus is not controlled. Thank you very much.
Anyone has any questions?
Learning, I don't know, but thank you very much. The very basic I wish there were more residents for this talk, this beautiful talk. There are, of course, many ways of skinning a cat, 9 ways, they say. I do a little differently. Over the period of years, like what you do the burr hole for the hydrocephalus children, we used to do regularly. currently I do it much less. I go down below the foramen magnum, if there is hydrocephalus, and open the dura below the foramen magnum. I don't have to take out the C1 unless until there is tonsillar herniation, and I release the CSF. And that has many times avoided another burr hole there. Of course, it's never, but there has been a change in my practice. That is one. The second one, I didn't understand. You gave some pictures of the dural incisions. And though I see that your pictures are the classical Y,
Yes, the dural opening.
dural incisions, but the other pictures inside, the diagrammatic representation, you had a transverse cut and then a midline cut. Is that what you're showing, or I didn't understand?
No, we do it Y or U.
Yeah.
You have to open the sides. In the sides, you're less inclined to find occipital sinuses, and then you approach the midline
But you had
carefully
some
from both
diagrams
sides.
where showing
These are pictures for how not to do.
Okay, right, all right, I got it, thank you.
And about
Any
the
other
hydrocephalus,
question?
if a
Anybody?
patient,
Just, Mahapat, he's telling something. Yeah, please go ahead.
yeah, if a patient is an infant, if a patient has massive hydrocephalus before surgery, I would rather put a drain because I would rather work on a soft cerebellum. And opening below the tumor not always gives you a good relief of pressure on the tentorium from above. So that's case by case. Moni.
Shlomi, two comments, if I may. One, with regards to the drain, for the hydrocephalus, usually I only relieve pressure after the bone is out, because we saw just a few weeks ago we saw upward herniation, although very rare. So if you put a drain, as soon as I'm in, I do not drain almost anything. Wait to expose the brain, taking out the bone, taking out the bone, and then I start to drain the ventricles. The other thing is the importance of the ventricular drain is for the post-op management, because it reduces the pseudomeningeal seal and the CSF leak, and we usually gradually elevate the drain until if we can't take it out, otherwise we put a shunt in. So it is very, very important for those patients who have hydrocephalus, but sometimes even for those who doesn't have, to put a drain before surgery, and to relieve the pressure from the cisterna magna is also very important. Then you can see everything is very nicely relieved. So I do both procedures. Yeah.
Thank you, Moni.
Yes,
yeah, how to deal with the hydrocephalus is really also a religion, but it's center by center. For example, I heard a very interesting comment from our friend Muhammad al-Batalgi in Cairo. Muhammad told me, in Cairo, 100% of the drains gets infected. So he puts shunts. He's never seen upward herniation. I've never seen upward herniation. It might happen if you drain uncontrollably.
Shunt.
Then you may have upward herniation. But if you put the drain and close it, and then wait for the other side, then I think you can avoid it. But this is center by center. It's tradition by tradition. Sorry, Dr. Manas.
Okay.
I know, we open the dura like a crescent shape on one side, and it goes below the marginal sinus to the opposite. So our primary closure rate is almost 95%, and pseudomeningocele rate has significantly come down, because that preserves the venous drainage from occipital sinus to marginal sinus. And primary dural closure also is 95% we get it.
Yeah.
We don't do that Y shape because
I understand.
I published
For
it.
me,
two
dural
papers.
closure doesn't work in the posterior fossa as much as I try. There are always holes here and there. So being lazy, I'm very lazy. With Jonathan, we just put a taco seal or something, but it's a good point. To open so that you can close. I hear you.
Okay.
Thank you.
I think we'll have next one, please.
Moni, come.
Okay, nice.
When I was a resident, we were forced to close the door or the shop. Yeah. You had to look for the dura, to dissect it from the bone. So, but nowadays we have the Duragen and the Taposil.
Duragen has no
So first I put the Duragen, then I put the Taposil. Now I put them both.
in another.
The Duragen, afterwards the Taposil. And I
It
put
costs
the,
money, a lot of money.
subcutaneous drain also. And all of this to
Who
avoid
pays
the
for the
CSF.
also patient? Who pay for it?
Yeah, it changes your perspective, for sure.
The patient has to pay.
Okay, so I'm also an epilepsy surgeon doing in epilepsy. In our hospital, we have an epilepsy center with a very, very good neurologist, which are the most important part of the epilepsy center, although we like to think that we are the best or the most important parts in everything in our lives. So yesterday we went to the Kunar temple, the Sun temple, and the guy told us, first of all, keep your ego out, okay, before you go in. So to leave our ego out and perform neurosurgery and the epilepsy surgery, I think it's the most important thing. So when we do temporal procedure, when we do epilepsy surgery and temporal lobectomy in children, there is a question what to do with the hippocampus. I will describe a few things about the hippocampus, why do we need to operate epilepsy at all, and then we'll see our techniques to avoid or to decide whether we need to perform hypocampectomy or not. So why to operate patients with intractable epilepsy? So there are many papers that were written, and actually epilepsy is one of the subspecialties in neurosurgery that we have more evidence-based medicine than in other fields. And there are many papers that are speaking mainly about the quality of life of the children and patients with epilepsy who are seizure-free. They have more ability to get married. They have more options to walk. They can drive, and many aspects of quality of life. And we have to remember that patients with intractable epilepsy may experience sudden death. And the life expectancy of patients with intractable epilepsy in the Western world is around 45. So we want to operate patients with intractable epilepsy, and we see the seizure freedom with time for patients who had surgery in opposed to patients who were on medical therapy. So why to perform temporal surgery? So this is a paper that probably most of you heard about it from 2001 by a group from Canada that performed randomized controlled clinical trial, and they had 80 patients, and they divided to two groups, one the medical group and the other one the surgical group, when they performed temporal lobectomy and hippocampectomy, and they found much better quality of life and seizure freedom in patients who were in the surgical group. So why do we need to perform the surgery in childhood or early surgery of epilepsy? Again, many papers that speak that the seizure duration goes with the inability to reach seizure freedom and lower quality of life indexes. And here, this is an example of adult and children with intractable epilepsy, and we see that in children the average before surgery was 5.4 years, and there is no doubt that for the children that will operate earlier, the seizure freedom was better. So why do we need to perform early surgery, temporal surgery in children? So again, many papers that we and others published regarding the surgical outcome of patients with intractable epilepsy, but we have to remember that temporal lobe epilepsy, which is the most frequent etiology for intractable epilepsy in adults, we can see it in children only 30%, so most of the children do not have a temporal lobe epilepsy, but extratemporal lobe epilepsy. So just a reminder of the hippocampus that is located in the mesial aspect of the temporal lobe and then climbing up and has the hippocampal shape. It is located in the, we can approach the hippocampus through the temporal horn of the lateral ventricle, and we have to remember the hippocampus has very important role in memory. The left one, the dominant one, is mainly involved in verbal memory, while the right one, the non-dominant one, is mainly involved in visual memory, and it's involved in spatial abilities, and we see that there is hippocampal atrophy in patients with Alzheimer, patients with schizophrenia. We can see some signal changes, and we all remember, or we know about patient HM, a patient that was operated in the 50s by Penfield, who had bilateral hippocampectomy, and we know that he lost his short-term memory, and the longest memory that he had, it was for the last 5 minutes. So he could do something, went out of the room, went back, and never remembered that he was in the room. He never remembered what we spoke, and never remembered what he did. Patient HM died a few years ago, but is a very important character in the epilepsy world, because we know many things that about hippocampus and the hippocampus function from this patient. So in adult, the temporal lobe surgery caused mainly in the left side, in dominant side, can cause some impairments of the verbal memory in these patients. But we know the seizure duration, older age at surgery, and intact memory before the surgery were risk factors for loss of memory. So when we need to go to hippocampectomy in adults, in adults with temporal lobe epilepsy, intractable temporal lobe epilepsy, we look at the hippocampus. If we see atrophy, if we see signal changes, and then we know that there is impairment of the verbal memory before surgery, we are safe to resect this hippocampus. But if the hippocampus is normal in MRI, and there is a normal verbal memory function, we are not safe at all, so we do not touch this hippocampus. The problem is if this hippocampus has some radiological changes, or if it's not functioning well, but the radiology is normal, what to do in these patients. In the past, I used to resect the hippocampus, but currently I resect the dominant hippocampus only if we see abnormal verbal memory function and abnormal hippocampus by MRI. Also in children, we see some verbal memory decline even in the long term, and we also published a meta-analysis a few years ago speaking about the inclination of verbal memory in children after epilepsy surgery, again, especially if it's in the left hemisphere. And we have to remember that since children with epilepsy, children have brain plasticity, significant brain plasticity, sometimes we see that the functional areas are going somewhere else. So there is, sometimes we can see interhemispheric reorganization, not all the time, of language cortex. We can see that there is some different of language patterns in children with epilepsy, and but the potential of relocalization of verbal memory in children younger than 5 years of age is bigger than children older than 5 years of age, and all we know that children has better plasticity, although sometimes they have some verbal memory or motor decline after surgery. So as I mentioned, temporal lobe epilepsy in children is not common. The etiology can be lesional, and lesional can be neoplastic, tumor, or non-neoplastic. It can be non-lesional, so normal MRI. Sometimes we see dual pathology, and as I mentioned before, the hippocampus can be absolutely normal. And I always remind you what is the goal of epilepsy surgery. The goal of epilepsy surgery is to resect the epileptogenic zone while preserving the functional areas. So like in any other neurosurgery, the diagnosis is also always retrospective. If you go to surgery and cut part of the brain and the patient is not has no epilepsy, so you were in the right place, you were in the epileptogenic zone. If the patient has no functional or no neurological deficit, you know that you will not in a functional area. But it's always a post-op diagnosis. So we usually try to perform before the surgery many diagnostic studies in order to avoid a neurological deficit. The most important one is neuropsychology. Neuropsychology gives us the ability to know whether the area that we want to operate is already involved or impaired, and tell us if we are in the right place or if we can take it out. So I present our experience. Currently we have more than 30 children. We are approaching 40 children with temporal lobe epilepsy. I will show you some case studies that just to show you some case illustration, what we do in our process in order to know what to do with this hippocampus. So, and many times we have to remember that the epilepsy is tumor related, and most of the tumors in children that cause epilepsy, the temporal lobe, are benign tumors. Can be either DNET or ganglioglioma. The tumors themselves are inertic, and what is epileptogenic is the brain surrounding the tumor. So the tumors themselves are electrically inert. So this is the first illustration. This is a 6-year-old girl with intractable epilepsy, and you can see this tumor that is located in the left temporal side, just beside the Wernicke area. So what we did, we took her to the OR. We performed intraoperative ECOG, EEG. When we, and as you could see in the MRI, the tumor approached the cortex, but here you cannot see anything. So actually all this area is tumor, although it looks like a normal brain. So we perform EEG, we see what are the patterns of the abnormal EEG. We go to the tumor, we resect the tumor, and then we perform another EEG, and then to see that the epileptogenic, the epileptiform discharges just disappeared. If it didn't disappear, we may expand the resection. And this is the post-op MRI. Another example of a 15-month-old boy that was born with epilepsy just a few weeks after he was born. And then he had EEG and then MRI. And then he had normal psychomotor development, but eventually became intractable. And then we took him to we performed MRI, and what you see in the MRI, you see this cyst. Sorry, no. Is it working? Not working. So you see the cyst attached to the right hippocampus. So we thought that epilepsy is coming from this cyst, and you can see the right temporal horn. So what we did, we opened the temporal horn, and then we performed intraoperative ECOG directly from the hippocampus. We call it hippocampal ECOG. So this is the hippocampus. We put electrodes on the hippocampus. Then we penetrated the cyst. We opened the cyst. This is the only thing that we did. We opened the cyst into the temporal horn, and then we performed another ECOG, this is the MRI after the surgery. You see that the cyst didn't go, but there is less pressure on the hippocampus, as you can see here. Less pressure on the hippocampus, and the child is actually seizure-free. Another example of a 6-year-old girl with 2 years of complex partial seizures that in her neuropsychology there was a decreased verbal memory, and the EEG showed that her seizures are coming from the left temporal lobe, and we see this lesion attached to the hippocampus and compressed the hippocampus. So we took her to the OR, resected this lesion, performed intraoperative ECOG from the hippocampus, and we found that there were no, to begin with, there were no epileptic-formed discharges from the hippocampus, so we didn't touch the left hippocampus. This child has no neurological deficit, and she's seizure-free. Another one, and that's it. Another case illustration of a 16-year-old girl with complex partial seizures. For the last 4 years, she was on multiple drugs, no febrile seizures, and you can see here, the lesion here, attached to the hippocampus. So we performed video EEG. I hope it will work, yeah. Video EEG, and you see that we performed the EEG while she had an exam, and you see she's already seizing. You see this abnormal movement, the abnormal head movement. This is a complex partial seizure. Why complex? Because she has some impairment of her awareness, and partial because only part of her body is involved in the seizure. Now the teacher that was watching her, calling her mom, okay, to see this abnormal behavior, she remembers nothing about this situation. So you saw the tumor that was attached to the hippocampus. Again, we exposed the hippocampus, performing hippocampal electrocorticography, and we found abnormal changes. We resected the tumor, and we repeated the hippocampal ECOG, and we found that there was still abnormal epileptiform discharges from the hippocampus, and we decided to resect the hippocampus. And you can see now the final stages of the hippocampectomy, and thanks for Dr. Carlos Candenedo from Panama, who helped me in editing this video. And you see the resection of the hippocampus, and actually it was in the right side, and we knew, according to the neuropsychology, that she had normal visual memory, and we knew that she may have some decline in her visual memory. Still, we decided to take the hippocampus, and this child is seizure-free. And actually, I operated this child about 7 years ago, and 2 months ago, her sister is a medical student in our university. She bought me cookies that this child baked, and she's this child that we operated, then she was 16, now she's 23. She's a student for mechanical engineering, and she wrote me with the cookies, "You saved my life." Well, I didn't save their life, but I saved her from her seizures. Sometimes we see non-lesional temporal lobe epilepsy, and in these children, we have to perform some intracranial monitoring. This is the stereotactic EEG. In the past, we used the grid, but now we use many stereotactic EEG, many electrodes going to the brain, monitoring the epileptogenic zone for a few days to a few weeks. We can leave these electrodes in the brain for up to 4 weeks, and we try to find, to locate the epileptogenic zone. We found in our study that the resection of the mesial structure did not change the seizure outcome. It's important in children. What to do next time with the hippocampus, it's a good question. So we found excellent outcome when we try to preserve the hippocampus, but sometimes we need to resect it, especially in glioneural tumor. Intraoperative ECOG is a good technique for young children. It's not a good technique, but this is the best one that we have. It's a safe, relatively safe procedure, Shlomi, as you mentioned that there is no safe procedure, but the complication rate is usually low. The major complication of temporal lobe surgery is injury to the visual field, hemianopsia and chondrotopsia. And another important issue is neuropsychology and teamwork. Again, I have to mention the Bivas family that was kidnapped and still in Gaza Strip. There will always be in our heart. Hopefully they will be saved soon. And thank you again. This is Rambam Healthcare Hospital at night time. Thank you.
How reliable is neuropsychological assessment in small children in quantifying the verbal and non-verbal memory?
Well, it depends on the neuropsychologist. Neuropsychology, like in many others, other diagnostic tests, is sometimes is subjective. Depends on the examiner and the examinee. If you have experienced neuropsychology, it's very, very important.
I saw you operated on a less than 3-year-old child.
Oh no, yeah. So neuropsychology, you ask for younger children? So for younger children, it's less accurate, indeed less younger than 5 years of age. But for older children, it's very important. For younger children, it's problematic. It's not really.
How do we balance between seizure control and preservation of memory, especially if you know that hippocampus is the culprit and the epileptogenic zone?
Well, it depends. Depends what we see in the MRI. If the hippocampus itself has normal shape and has no signal changes, and in neuropsychology, the hippocampus is normal, so there is no impairment, we don't touch the hippocampus. If we see abnormalities in the hippocampus itself and there is decline in verbal memory in neuropsychology, we think that we can be safe in resecting the hippocampus because this hippocampus is not functioning anymore. For other cases, it's to consider whether to resect it. In the right side, the non-dominant hemisphere, we always take it out if we need, but in the left side, we try to avoid it.
It's okay? It is? If no other, any?
Slightly different question. If you have a lesion, you have your developmental tumor next to the hippocampus, and your MRI hippocampus shows no change in the MRI imaging, and the patient has epilepsy from that side with your video EEG or whatever. Would you go for it or you leave it?
You will have to.
Well, again, it depends. Depends on neuropsychology. Depends if it's in the right side or in the left side. We use the ECOG. If it is in the right side, the non-dominant side, I will consider to resect it rather than to leave it in. But in our epilepsy center, we have long discussions regarding what we are going to do in surgery. Depends mainly on the neurologist. If the neurologists tell me that the semiology of the seizures are definitely coming from the hippocampus, I have to trust him.
No. I'm sorry, I didn't make myself clear. The semiology is not coming from hippocampus.
Well, it's mesial structures.
Yeah, mesial
semiology
structure.
can come from the mesial structures. Yeah. Okay. It's coming from the mesial structures. But if it says it's coming from the mesial structures, and if it's in the right side, I will take it out. If it's coming from the mesial structures, and again, the neuropsychology is normal, and the MRI is the hippocampus in MRI has no changes, no atrophy, and no signal changes, I won't take it out.
And the corollary to that question is, do you have data? What data have you got to say that the lesion on the right side, if you just remove the lesion and leave the hippocampus, which is normal, the epilepsy control is better? You have had data about it?
Resecting the lesion without hippocampus?
That's correct.
No, we have data that shows that there is no difference.
So why take it out?
Because well, this is a good question. This is why I gave this lecture, that we don't really know, but we take it out, as you see, according to the electrocorticography, and because we know that sometimes in the long term, okay, patient may develop if it's tumor, for example, the seizure freedom is 90%. if we take only the tumor. But in the long term, 10 years after surgery, there are papers. We published paper that showed that there is a decline in seizure freedom, and sometimes you need to go to the hippocampus. Second surgery to the hippocampus, the right side, it's a second surgery. So sometimes we prefer to take it in advance according to the hippocampal ECOG.
Before these people go on to develop the second, the secondary epilepsy.
We're speaking about children, yeah?
Children, I'm talking about children.
Okay.
This is from Jim Rotka's group. So if you have the epilepsy, or the tumor-related epilepsy in a child, which has been there for quite some time, it makes sense to probably take out the adjacent areas, including
because the tumor itself is inertic.
That's right. So if you if you have a very early on taken out, I don't think there is enough data to suggest that removing that, the extra hippocampus, which is normal, does add any benefit.
Yeah, I agree on that. If it's a recent onset epilepsy, lesionectomy is as good as lesionectomy plus or lesionectomy plus hippocampus. If it's an old epilepsy and there's kindling, you may be tempted to go more mesily, but that's case by case.
Well, I was speaking about intractable epilepsy. For recent epilepsy, lesionectomy is usually enough because the cortex around the tumor is probably still preserved. We know that there are sometimes we speak about dual pathology. Dual pathology meaning that there is hippocampal changes in pathology in the hippocampus and changes in the surrounding brain. Although we try to avoid even frontal lesions or temporal lesions, we try to avoid, but sometimes we need to take the brain out, not only the lesion. This is why the right hippocampus may sometimes go out.
Very good lecture. Thank you very much. Thank you. Dr. Manas? I think everybody know him, so there's no point. I think he has several talks.
Good evening, chairpersons. Morning, we had a paper on ETV and few of the complications. So I'll be speaking on how to avoid complications in ETV. In third ventriculostomy means, though it is better in than shunt in certain indications, but it also has some complications, though it's not very high. It can be avoided if done properly. There are many complications. One of them, is bradycardia if during surgery, or intraventricular bleed, pneumocephalus, fornix injury, hypothalamic damage, cranial nerve damage, and hypothermic disturbance or temperature regulation in following third ventriculostomy. I'll explain how to avoid all of them. Now, this paper was on complications, and then the most commonest is a CSF leak. I'll show a slide what we do to reduce CSF leak. The other complications are hemorrhage, hypothalamic injuries, all 1 to 1.5%. So in total, the complication rate is around 13 to 14% in third ventriculostomy. Now, to avoid complication, the best is to start from the beginning, analyzing the MRI rather than just concentrating on the surgery. The pre-op image is the most important thing. Look at the size of foramen of Monro, because your endoscopes are 6 mm diameter, and if your foramen of Monro is less than 6 mm, then probably then it's probably not worth doing third ventriculostomy, because you might damage the foramen of Monro. Look at the diameter of the third ventricle. The endoscope again is 6 mm. If the diameter of the transverse diameter of third ventricle is less than 6, then it is better to avoid and look at the prepontine space. And if especially in a posterior fossa tumor, when you're planning third ventriculostomy, the prepontine space is significantly reduced, and if it's reduced, doing a third ventriculostomy can cause catastrophes. So like this patient who was referred to us for third ventriculostomy and biopsy of the posterior third ventricle, when one sees here, the foramen of Monro is very small. And doing, so we did not attempt third ventriculostomy, we suggested for microscopic surgery. Whereas this patient who had pineal tumor with a large third ventricle, can see here the transverse diameter is more than 6 mm and the foramen of Monro also is more than 6 mm. So these are good cases for third ventriculostomy and biopsy of the posterior third ventricle. And this is a lesion, the large is a fourth ventricular outlet obstruction. There is hardly any prepontine space, and if you do not have any prepontine space doing a third ventriculostomy, the chances of basilar artery injury is high. And this is similar when you have a large posterior fossa tumor, the prepontine space is obliterated. In those cases, again one has to be very careful in doing a third ventriculostomy. Now, damage to fornix happens if the foramen of Monro is small or if the angulation of the endoscope is not done properly. Like here, one has to plan the proper trajectory. To plan the trajectory, one can take a point on the dorsum celli, take a midpoint of the foramen Monro and extend it onto the vertex. And that is the point of entry of the burr hole you have to make for the endoscope to go. But then if one does not do that properly, one does an anterior burr hole or posterior burr hole, then one has to manipulate in the foramen of Monro, in turn cause fornicial damage. So plan your trajectory properly, use navigation or use manual calculation to do a proper burr hole. Do not do an empirical Cocker's point just in front of coronal suture, because it varies from person to person. Do a customized burr hole. So if one plans a third ventriculostomy, do as from the dorsum celli, midpoint of foramen Monro and project it on the vertex. But if one is planning a biopsy of the posterior third ventricle, then take the point of biopsy through foramen of Monro and project it on the vertex, and that is the place for burr hole to do the biopsy of the pineal region. And so if one is using a rigid endoscope, it's better to do 2 burr holes, and if one is using a flexible, one can do with 1 burr hole. So we use a rigid endoscope, so we make 2 burr hole if we plan to do a third ventriculostomy plus an biopsy of the posterior third ventricular region. So this is a video of a classical third ventriculostomy. As soon as you enter, if your trajectory is proper, the first thing you will see is the foramen of Monro. Now this is the septal vein, this is the choroid plexus, the thalamocaudate vein. And as you enter, one sees both the mammillary bodies. In front of that basilar artery is seen here, and this is a dorsum celli, and the premammillary membrane is very thin, and then one can perforate that in front of the basilar artery. And once you do that, do not inflate your Fogarty catheter inside, because if you inflate it there, you might cause compression or stretching of the perforators of the basilar artery inside, and can cause bleed. So always lift the floor of the third ventricle into the cavity of the third ventricle. As you see here, I lifted the floor of third ventricle into the cavity, and as I widen, so there is no stretching, means I am away from the basilar artery perforators, and so the chances of basilar artery perforator injury and bleeding are less. And success of third ventriculostomy depends on looking for the second membrane. Once you have done the third ventriculostomy, one has to go beyond the third ventriculostomy and then look for the bare basilar artery. There should not be any second membrane. That is a completion of third ventriculostomy. And then we use the second burr hole for taking out lesion of the posterior third ventricle. This is the posterior commissure, this is the aqueduct, this is the pineal recess, and this was the tumor compressing or bulging into the aqueduct. So you can use a laser or a Caesar or use the Fogarty catheter to cut the ependyma, and then use the same Fogarty catheter to make a plane between the lesion and the ependyma. This was a cystic lesion. It's always better to remove cystic lesion in toto. Once you dissect with the Fogarty catheter, then hold the cyst, do alternate clockwise, anti-clockwise rotation so that it is dissected from the surrounding structures. Do not pull it off. That's what we do, alternate clockwise and anti-clockwise rotation, so that it helps in dissection. And then remove the cyst in toto. The cyst will be bigger than the channel diameter, so take out the cyst along with the endoscope outside totally together, because if you pull it through the channel cyst, the cyst will rupture. So endoscope and cyst is removed together. Now, how do you prevent subependymal bleed? Because subependymal vein injury is blind. When you puncture, it can suddenly bleed when you are placing the endoscope. To prevent subependymal vein injury, what technique we use? We use brain cannula. We just cut the digit of the globes, tie it on the brain cannula, and then we can inflate the brain cannula like this with a syringe. So what we do is you place the brain cannula with the digit globe and tap the ventricle and then inject it. So the whole tract from the ependyma till the cortex with mechanical compression becomes avascular. So when we place your endoscope, there is no bleeding. You do not have surprises. There is no subependymal bleed. Always do a continuous irrigation so that the tract remains open. One can see here. So one need not use sheath. With the tract we have created, you can go multiple times in and out. See the avascular tract, and if you have a continuous irrigation on the endoscope, you can go multiple times in and out without any problem. The next important thing what you see in a pre-op MR is the thickness of the floor of the third ventricle. Always do a contrast MR, especially in our conditions when we do post-TBM or post-meningitic hydrocephalus. If the contrast MR, the thickness of the membrane, floor of the third ventricle membrane is very thick, then probably it's better not to attempt third ventriculostomy because it will be opaque. One cannot see the basilar artery, and it may be very thick to open that also with the available instruments. And especially when you're pushing our Fogarty to make a perforation, it might cause traction on the lateral wall of the third ventricle, and that causes hypothalamic damage. So like here, so if it's a thick membrane, probably it's better to avoid third ventriculostomy. So this is a case of a thick membrane. Whenever the thick membrane, when we do not see the basilar artery, it's better if you have already opened it, better to feel the dorsum celli with the instrument or a dissector, and then incise it over the dorsum celli, or use a laser. Whenever one is introducing an instrument, never introduce inside the third ventricle, yet as the first 2-3 millimeter is blind, it might cause inadvertent damage. Bring back your endoscope to the lateral ventricle, then introduce instrument, either your Caesar or laser. So always introduce an instrument in the lateral ventricle, never in the third ventricle. This is a case of a shunt malfunction. You can see here the floor is very thick. So we use laser because we could not puncture with the Fogarty catheter. We use laser to perforate the membrane. And then finally use Fogarty to enlarge that opening. And then see that there is no second membrane. How do we avoid vascular injury? This is the most dreaded complication. This is a case in 2014 I had this complication. This was again, as I had explained, there was a very less space in the pre-pontine. There was no space between basilar artery and the dorsum. And I'll explain what mistakes I did in this video. First, my indication was not correct. Second is I perforated, and then I inflated the Fogarty blindly below the floor. I did not lift the floor of the third ventricle into the cavity. So I dilated below the floor. One of the perforators of basilar had snapped because I inflated the Fogarty below. And this is what happened. And but then one need not panic. One need not so that it's the end of the day, I have lost the patient. The most important thing is never bring out your Fogarty catheter immediately. When you deflate it, do not withdraw. Keep it there. Because my Fogarty catheter was there, I could inflate the balloon immediately and the bleeding stopped. And then I had to wait for half an hour to achieve hemostasis. So don't be in a hurry that third ventricular stream is done, that deflate and pull it out. Then you'll have no control. If it bleeds, you cannot see anything. Do not deflate it, wait for 1 minute till you see that there is no bleeding, and then only pull out your Fogarty catheter. So this is how we could save the patient. So I kept on waiting. Every 5 minutes I deflated, it was bleeding, and at the end of finally at 30 minutes, as you see here, intermittently I used to deflate, and at the end of 30 minutes I could achieve hemostasis. One can do an MR angio and integrate, but then after endoscopy there is a shift, so it may not help so much in avoiding basilar artery injury. The best is to do not to withdraw and widen the floor of third ventricle in the cavity of the third ventricle rather than below the floor of the third ventricle. Now, how do you avoid hypothalamic damage? All of us know that the lateral wall of third ventricle has the hypothalamic nuclei. So whenever you perforate the third ventricle with the Fogarty, and if it's very thick, that mechanical stretching of the floor of third ventricle stretches the nuclei on the lateral wall, and that causes hypothalamic damage, and that causes the changes in the post-op temperature. So if you have a thick floor, either use a sharp scissor, but don't do a blunt perforation, or use a laser. And especially in post-shunt or post-infective, laser or sharp scissor is helpful. And in post-infective, many times you find a third ventriculostomy. The success depends on the perforation of the second membrane. This is what we had published long ago in 2000, 2 papers on that. Always you find a second look for the second membrane. If there is a second membrane, then perforate that also. Now this is the video showing that the first we did, there was a thick membrane. This is the dorsum celli, the pituitary hypophysis, the basilar artery. First we did the third ventriculostomy, and then you can see here with the endoscope we went inside, we found second membrane, and again we use the Fogarty and laser to perforate the second membrane. And then we did an aqueductoplasty. Aqueductoplasty can be attempted in infants but not in adults. This is the aqueduct, and this is the posterior commissure. One should not dilate more than 2 to 3 millimeters of the aqueduct because the normal diameter is 2 to 3. If one dilates more, then one can have Perinaud syndrome post-operatively. The most common complication is CSF leak. The CSF, we follow this technique just published by Dr. Mohanty et al. From Bangalore NIMHANS, that we harvest a pedicle graft from the flap and then plug the pericranium, the cortical plug with that pedicle pericranium, and that has reduced significantly pseudomeningocele CSF leaks in our patients. Now how do you do third ventriculostomy in shunt malfunction? Because the anatomy is distorted and the floor is thick. I've already explained how to tackle with thick floor, but how to tackle with distorted anatomy. Now this is again a case of a third ventriculostomy following a shunt malfunction. The floor was thick. We used laser to perforate. Then there was a second membrane, and we perforated the second membrane. You can see here the second membrane. Again, we use laser to perforate the second membrane. As you can see here, always I lift the floor of third ventricle into the cavity so that whatever inflation of the floor is done is under my vision to avoid basilar artery perforator injuries. Now this is another case of a shunt malfunction. The foramen Monro was deformed, or adhesion was there, so we did a foraminoplasty. Foraminoplasty so that our endoscope can enter the third ventricle. As I had explained, if the foramen is small, it's better to avoid, but in this case, we could manage to do a foraminoplasty, widen the foramen, and then the foramen is widened and then followed by third ventriculostomy. Now what can you do when you have like this multiple loculated hydrocephalus or deformed? Like this is a patient, is a 31-year-old patient who had shunt multiple times, had come with shunt malfunction. He had a calcified subdural, which he didn't do but anything, but patient was symptomatic for the hydrocephalus, and he had a distorted ventricle. So we attempted again, we explained that we'll attempt a third ventriculostomy, and we did that. So if you have a deformed ventricles, deformed anatomy, then one needs to do either a navigation guided or robotic guided or an ultrasound guided, because it's sometimes difficult just to use anatomy to tap the ventricle. In children, can use navigation, or you can use the auto guide in adults, where this was a supracellular arachnoid cyst with a small ventricles, and so we thought it would be difficult to tap the ventricle, so used auto guide of Medtronic to tap the ventricle, then dilated with saline, and then we did a cystoventriculostomy and cystocystonostomy. This is what we do. We target the center of the frontal horn, use the biopsy needle, again use the same technique of digital globe to create, first inject saline to dilate the ventricle, then dilate saline in the digital globe to create the tract, and use with the robo, the endoscope is guided through the robotic trajectory, and this is something which we have done in our own hospital, because they don't sell the reducing sheath, the company doesn't sell this sheath. Now, if you do not have a robo, one can use ultrasound. In an ultrasound, one can do 2 burrows and do an ultrasonic guided tapping, followed by dilatation of the tract, and do your procedure. So navigations is done only, not all the cases, only if you have a narrow foramen of Monro, you have craniostenosis, or in small ventricles, or when you have a multiloculated hydrocephalus. In conclusion, complications can be reduced significantly by doing a pre-op interpretation of the MR, intra-op precautions, and use of navigation whenever it is indicated. Thank you for your attention.
Thank you, Manas. Any question? Anybody? Yeah.
So overview, Manas. There is, you sort the laser thing, which may not be available everywhere. So the other thing we do when it is a thick, very often even the non-meningitic hydrocephalus, the membrane is so thick that it doesn't perforate with a Fogarty. So what we do is we put a very low current, the bipolar, with a two-tip kind of bipolar, and so it makes a hole. Okay. Usually at the setting of 4 or 6, usually 4, sometimes 6, and maybe 3-4 times at 2-3 different points, and then we get a hole and we put it in. That's one of the things we do for membranes. That's number one. Number two, the 2 hole for the biopsy and the ETV. I don't know whether if you're any young neurosurgeon this. The critical thing to have the ETV first, because if you have a bleed, then your field get muddy, then you may not be able to do it. So our primary aim when you do that is first ETV always before we attempt biopsy, and sometimes we may not be able to do it. One of the problems with 2 hole is when the ventricle gets decompressed, Putting the second endoscope sometimes is difficult. And because the ventricle has collapsed unless until you have filled it up. So that's one of the cautions we have, we think should be there. And what about the irrigating solution? What do you use? Did you tell? I missed it, I didn't. What irrigating solution do you use?
We use Ringus lactate.
Yeah, so it's very important again that it should not be cold because our AC temperatures in the theaters are very cold. So it would be advisable to use the little bit of warm, that ringer. We also use the ringer thing.
Yeah, the third, we always follow first third ventriculostomy followed by biopsy. It is difficult to tap the second, from the second burrow. So what we do is, when the endoscope is in with continuous irrigation, ventricle is dilated, that time you do the tapping, so that it is easier.
Dr. Girish?
Manas, I saw that you did a lot of post-meningitic, post-infectious hydrocephalus. ETVs.
Post-shunt malfunction also.
Yeah, so what is your experience with this? Because general classical teaching is for obstructive hydrocephalus, so what is your long-term outcome with post-meningitic hydrocephalus and ETV?
Yeah, means it's not communicating post-meningitic hydrocephalus. They are obstructive post-meningitic hydrocephalus where you have aqueductal stenosis. And most of the time when it's a shunt malfunction, because of the drainage of the fluid, patients develop, though it's a shunt was done for a communicating hydrocephalus, when there is a drainage, they develop acquired aqueductal stenosis. So we have patients who have scans treated with a shunt for communicating, but when they come with shunt malfunction, they have become obstructed with an aqueductal stenosis. That is acquired aqueducal stenosis. So those cases we have attempted, and we have got 70 to 80% good success rate in those cases.
Any experience with ETV for normal pressure hydrocephalus? Because some people's advice.
We don't practice for normal pressure.
Okay, thank you, Manas. Manjul, Dr. Manjul. Manas, before the Manjul, put the slide.
Dr. Mazhar Hossain, who have a series of post-meningitic hydrocephalus treated by ETB, they have some reasonable success, but it's very, we don't do it. But Mazhar has published it, yeah.
I was asking, have you done endocrine abnormality study after the ETV? Hormonal assessment, because and now you don't bother for hormone.
So
hemodynamic change, na?
Laser is something urology people have in many of the hospitals. So thulium laser, which I think many hospitals have. What we use is we use a neuro-dedicated laser, which the company has stopped selling it. But the urology laser is the same. It's only more expensive. Yeah, that is only 0.2 millimeter. So it can go the fiber. It's optical fiber. So we use it for open surgery also, for meningiomas.
No, it goes through the endoscope channel.
Yes.
Manjul.
Good afternoon, chairpersons, and my father is a pediatrician, and in my childhood I decided that I would be anything in the medical career but a pediatrician, because I was severely irritated by the shrill cry of those patients with whom I had to share my study room. And as the luck unfolded, I fell in love with a pediatrician, which happens to be my wife. So ladies and gentlemen, with this dual degree of having two pediatricians in my home, I was honored with this responsibility to speak on this difficult topic of the pediatric parenchymal tumors. And when I looked at the program, scientific program, it was a nostalgic moment for me since coming back from Israel at that time, and this is here me in solidarity with the Israel against the Holocaust Museum. These are my disclaimers, and this talk is based on my personal experience and literature review of close to around now 5,000 patients of gamma knife, out of which nearly around 300 patients were the pediatric patients. And when I say the pediatrics, these are the children who are less than 12 years of age, not 18. So we recently published our experience of treating different indications in the pediatric population. Over the course of time, the number is gradually increasing because of the gathering confidence and experience in the pediatrics department from which the patients come, our colleagues. And most of these, if you look at the indications, most of them are actually the vascular pathologies, which are the AVMs. And if you look at on the x-axis, you can find that there are various indications which we have treated over the course of this time. We started with the adult radiosurgery, and then we extrapolated our results in the pediatric population. But once you talk about the pediatric parenchymal tumors, it becomes a little difficult because these are the infiltrating tumors, and many a times you are not sure about the boundary of the tumor and the margin. But they remain the most prevalent solid malignancy in this age group, and they remain the most common cause of the cancer-related mortality in the childhood. The current standards and the classical teaching is the maximum safe resection, followed by the adjuvant treatment in the form of chemotherapy and radiotherapy. But SRS is a different point of view, especially in a developing brain because of its specific dosimetry, radiobiology, and the sharp dose fallout. And this may prove to be a potential solution as far as the long-term quality of and the outcome and the progression-free survival is concerned. But this is a tender age, and in this age, you need to strike a very fine balance between your indications, expectations, and the reality, because these patients need to be followed for a very long duration of time. Because they are not adult, their brain is different, their pathologies are different, their tumor biologies are different. As Dr. Shlomi told, it was adamantinomatous in childhood, but the papillary in the adult. They have distinct treatment protocols which are pertaining to those developing brain. They have a greater susceptibility and chances of toxicity because of their greater sensitivity. And since we expect them to have a longer life expectancy, the chances of having complications in the long term are also there, which you need to balance and take into consideration while treating. Especially when you are treating these patients with the frame-based stereotaxy, like with the perfection, you need to be really careful because their skull are thin, they are deformable, there might be target error because of this. Many a time, they are having hydrocephalus, so they come at a higher chance of the CSF leak. And it may move if you are treating them with a frame-based stereotaxy. Gradually, we are moving from the frame-based to the frameless stereotactic gamma knife radiosurgery or the cyber knife or the other stereotactic procedures. Whenever you are treating a child with radiosurgery, that's actually applicable to any surgical approach. You are not only treating the child, you are handling the whole of the family, and there are significant anxiety issues, especially when they see the frame or the mask over the patient's head, and then there comes the role of a gamma nurse coordinator, which has to ease the patient. If you are doing with the frame-based, which is still the practice many places, then you should put it under GA. You should have a proper access to the airway because you may need to secure the airway at any point of time in those patients if they throw seizures or something like that. If you are doing with the frame-based one, a frameless one, the mask one, then you should have some extra opening, not only just for the nose, but for the mouth, so that you can intubate those patients. Always have an inverted V in those patients so that you have a complete access and a complete monitoring. Many a times you need a good teamwork with your anesthetist colleague so that you can continue the treatment. I have treated from 9 months to 92 years of age with different indications, and their requirements are different. In pediatric age group, you need a good anesthetic support. So for some patients, frame was definitely an issue, but with the frameless one, it has become much more easier, and to do the fractionation is also easy. Despite having all these kinds of safety checks, sometimes you face some difficulties. Like in this child, it was an exactly centrally placed face, the frame in a patient of resistant acromegaly, and had to stop the treatment many a times because machine was showing a collimation error where I couldn't find any collision with the machine at any point of time on the physical evaluation. What was happening whenever we were starting the treatment, the child started crying and those teardrops were falling into the gantry, and the machine took it as a collision error. So we had to intubate the patient, dry it out the whole of the tear, and then the machine could continue the treatment. Otherwise, it was considered as a collision error. So in today's talk, I am going to speak on intraparenchymal tumors predominantly, which include the gliomas, pineal region tumors, some metastasis, cellular tumors, posterior fossa, vascular, and the functional one as well. Starting with the gliomas, we have a lot of studies, which are usually the level 4 studies, some multi-institutional studies on the low-grade glioma, but those are mostly in the adult. It is a very heterogeneous group, but if you look at the long-term tumor control in the adult population, some of them have actually the patients in the pediatric age group, but their long-term tumor control rate is close to around 80% to 90% down the line 1 decade. The longer you follow, the patient control rate becomes less. This is a study which was done in pilocytic astrocytomas in the pediatric age group, in which the mean age group was 14 years and significant population was in the pediatric. 30% were in the brain stem and 2/3 had a cystic component, and they were treated with the 14 gray with a mean follow-up of 148 months. And you would be surprised that 39% were primarily gamma knife radiosurgery when they were treated over here. So with the 10-year tumor control rate, progression-free survival of 70% and overall survival 92.5%, you may argue that it might be just in the natural history of the disease, but this was the result. There was no significant impact of the dose on progression-free survival. The only negative factors were the prior radiation therapy. So what is more problematic in this patient population? Sometimes, like in the brainstem gliomas or optic pathway hypothalamic gliomas, it's not the pathological grade of the tumor, but the location of the tumor, which you may consider as a malignant one. Like this patient, an 8-year-old optic pathway hypothalamic glioma, grade 1, resected thrice, patient refused for any further surgery, disagreed for IMRT or any fractionation. So reluctantly, I tried it with the 10 gray at 50%. And this was the pre-gamma knife scan. And this is at the time of follow-up of 15 months. And you can see that there is a significant cystic degeneration inside the tumor. The tumor has gone away from the brainstem and from the optic pathway. It didn't disappear, but it has reduced to close to around 40% of its initial volume. This was from my friend Seljuk Pecker, who evaluated it for the tactile plate gliomas, which are usually subjected only for the observation or the conventional local field radiation. So they treated it with the gamma knife radiosurgery, and they had a good follow-up. Upfront treatment was in 46%, and they could find that the complete response was in 17%, where this was complete disappearance, and the partial response in close to around 69% patients, and there was no permanent neurological deterioration. Similar to him, I had been lucky most of the times. As you can see, he has given comparative evaluations over here. I also tried many a times. A couple of times I had a complication. Like in this patient, I had a intratumoral bleed, and I lost the patient after 6 years of follow-up. But another patient, another important pathology, which is a WHO grade 2, which is a central neurocytoma. Sometimes you find a residue over there because of your axis, or sometimes because of the massive bleeding. These tumors are known for having much more vascularity compared to the normal gliomas, but I found them very, very radiosensitive. And being inside the ventricle, you can be liberal with your dose, and this is the response which I usually see with the central neurocytoma. If I do not see this response, I go for a pathology re-evaluation, because I consider it a very radiosensitive tumor, and this is a consistent response which I am seeing down the line 2 months. The tumor is practically 90% gone, and you can have a very good long-term tumor control with this. As far as the literature is concerned, it is very fractured. Most of these studies are level 4. Publications lack the high quality data. SRS could be an efficient treatment modality, a potential treatment modality, as I have just shown in this patient population. But I cannot say that there is some specific guideline over there, and there is a lot of things which need to be evaluated, like the grade, pathological markers, dosing schedules, the temporal sequence with your contemporary treatment modalities. Coming to the posterior fossa tumors, the medulloblastoma, the conventional and the standard treatment is gross total resection followed by craniospinal radiation, but there are recurrences when you follow these patients or your patient lives long enough, and in those cases, giving a second radiation becomes a trouble. So if you have a focal recurrence, you can definitely go with a boost radiosurgery, and most of these patients are further having a good around 5 years progression-free survival when you give a boost radiation at least around 16 gray to the tumor. I have tried it in a couple of patients. Like this patient had already been treated in 2017, had a local recurrence, and then I had to treat, sorry for the quality of this image, but I treated with a 20 gray, and it had a cystic degeneration, and now this patient is now around 8 years follow-up without any recurrence in this patient. Pediatric ependymoma, which is furthermore difficult, third most common pediatric tumor, operate if you have a residue, reoperate, and then subject to the conventional radiation. But if there is a failure, which is actually bound to happen in the long term, then SRS can be used as an adjuvant treatment modality. It has been found that the complication profile is slightly higher in cases of ependymomas in comparison to the medulloblastomas, and the progression-free survival is not that robust. Whenever you are treating these patients with a salvage radiosurgery, always have a proper plan with the prior radiation therapies, because you might end up with the radiation toxicity if you make the hot spots over there which has been previously radiated. Choroid plexus tumors is an interesting group which we sometimes, not very commonly, we find. I was a part of this study which was under the aegis of the IRRF. And we found that nearly around 70% patients had more than a decade tumor control. Tumor either reduced in size or remain stable. So it can be a minimally invasive management option for the patients, irrespective of the choroid plexus papilloma grade. It might be a choroid plexus carcinoma also, but the histopathological grade did not adversely affect the outcome. It remained stable. This was my patient at PGI, which was treated in 2018. It slightly reduced with the circumferential reduction, and now it is in a stable situation, and it's close to around 7 years. Meningiomas, which is relatively rare in the pediatric population compared to the adult, and many times they are syndromic ones. 70% are close to around sporadic, with the most common site in the cavernous sinus. I again contributed to this study with the IRF. The upfront treatment was considered in 46% patients. We still consider that the gross total resection is the best treatment option, but if there is some residue and you are not able to remove it completely, then gamma knife is a valid treatment option. But these patients you need to follow for a longer duration of time, because the patients which we followed more than a decade, their progression-free survival reduced from around 86% from 6 years to around 69% at the end of the 10 years. Pediatric vestibular schwannoma, first of all, it's usually not a vestibular schwannoma, it's a neurofibroma, because most of these patients are syndromic ones with the neurofibromatosis type 2. And in those cases, our goal is not only the tumor progression-free survival, but to maintain the good quality of life for the longest possible duration of time. And in those cases, it's essential to strike a perfect balance of your microsurgical knife and gamma knife radiosurgery. Results in these syndromic vestibular schwannomas are slightly inferior. But if it is a sporadic vestibular schwannoma, you have done a genetic analysis, then you can be sure that this patient would respond with a good progression-free survival for the longest possible duration of time. NF2 is a particular patient population which is at a slightly higher risk of malignant transformation. But if you have to use any radiation, then definitely radiosurgery becomes a preferred and the easy treatment option comparison to the IMRT. We had a discussion on the craniopharyngiomas. So definitely there is an ongoing discussion going on between the protons and the photons. We have been doing single session gamma knife radiosurgery for craniopharyngiomas when it is away from the optic apparatus. When it has engulfed the optic apparatus or I am not sure about the tumor, I send them for an IMRT or offer them a proton radiosurgery, which most of the patients are actually not able to afford because of the financial reasons. But I agree that the proton has given a good results. But similarly, if you are able to separate it from the optic apparatus, even slightly lower dose up to the 10 gray is good enough for a craniopharyngioma. It depends on how is your craniopharyngioma. If it is a solid one, the response is better comparison to the cystic ones and the mixed ones. Sometimes we have seen that giving radiosurgery to a cystic craniopharyngioma paradoxically increases the cyst size. It might be at a slightly more aggressive pattern. But if you are with 12 gray and it is a predominantly solid or a mixed one, predominantly solid ones, your chances are pretty good. Best suited for the smaller tumors with the predominant solid component, ideally away from the optic apparatus. I never thought earlier that it could be effective for the rough case cleft cyst, but IRF conducted a study and then I found that close to around 25 patients were treated with radiosurgery for rough case cleft cyst when there was a residue, and in many cases with the primary radiosurgery. They had an excellent cyst control in close to around 75% patients with no visual and endocrine outcome. So it is definitely, especially, it's an effective treatment modality for patients with the no visual deficit, and it can be used both as an upfront or as an salvage treatment option. This is pediatric pituitary adenomas, which are usually functional adenomas and corticotropinomas. The SRS response for their residual tumors is similar to the adult counterpart, but oh my God, okay, so there are more chances of the hormonal deficiency. Hypothalamic hematoma, a different clinical entity, but it has a very long-term safety and efficacy with gamma knife, and earlier you treat, better it is for their epilepsy profile and the endocrine outcome. And we are coming up with a 39 patient series worldwide with the 9 centers. The earlier you give gamma knife, the results are better, and the results are equal to other treatment modalities like RFL or LITT. I'll just show this important case. This is a patient with the hemifacial spasm at 2 years of age with a certain dystonic posturing of the neck, and you can see the crippling one. And we could find a floor of fourth ventricular lesion, which might be a facial nerve hematoma or a glioma. The family disagreed for the surgery, and we treated it with the upfront radiosurgery with a 30 gray, and this is the result at the end of the 2 years. So now she's having just single episode of hemifacial spasm compared to the 30 to 40 which she used to have earlier, and it's maintaining on just 10% of the drugs what she was on earlier. You can use it as on the same principles of the disconnection as you do the microsurgical callosotomy for Lennox-Gastaut syndrome as a palliative treatment option. Fine. So this is the colloid cyst, primary colloid cyst. So I'll just conclude that which patients may actually benefit when you have a radiographic clear-cut margin, where the surgical intervention is deferred, when the SRS is technically feasible. A short comment on the pediatric AVMs is that their response is slightly better in comparison to their adult counterparts, and if you can operate, it's okay, otherwise, just okay. Concluding, sir. So it's yes, you can do it in all the patients as it's been promoted, but find your counter argument with the natural history of the disease in these patients with the intraparenchymal pathologies, and if you can't operate, then it is definitely a better treatment option and a safe option in these patients. Thank you.
Thank you. Yigal, please.
Manjul, thank you. I mean, interesting talk, because you are talking on, especially in the pediatric population, very various series. You present some data. Of course, the big question is not if we can do it, the question if we should do it. And I don't have an answer for this question, and there is not, a textbook answer for that. But one specific question I wanted to ask you: when you consulted the parents of a child that you want to give stereotactic radiosurgery, what do you tell them about the probability of developing malignant tumor down the road 10, 20, 30 years? Do you have any evidence to show them? What would be your answer?
Okay. So this is always a counter argument whenever you discuss, because I operate also and I do gamma knife also, so I have to strike that balance. And I offered that surgery to that patient because it was a very well localized tumor at the floor of the fourth ventricle. You can easily operate on that. And in these cases where I do not have any literature evidence to show to them that whether it would work or not, I extrapolated my experience of a hypothalamic hematoma, because my radiologist was sure that this is not having a choline peak, this is a facial nerve hematoma. So if hypothalamic hematoma responded in your cases, this might respond. The family disagreed for surgery. I told them that, okay, this is to be done, and there is around 2% risk of having a meningitis, and probably I might excise it, still some hemifacial spasm or dystonia would be there. They disagreed. It was a very poor family over there. So they disagreed for any invasive procedures. Most of these hypothalamic hematomas which I could do with the radiosurgery were actually offered radiofrequency ablation at several centers, or endoscopic disconnection, or open surgery. But when they disagree, then this is a salvage procedure which has been offered. And sometimes you just gather evidence in this way, because these diseases become the orphan diseases where nobody actually guarantees you a success, and then the family is in a fix because of those tender ages, and then they go towards the path of the least resistance, which usually falls in the category of the radiosurgery. So yes, over the course of time, I am gathering evidence over it. I do not say that this is the standard of care or it should be the gold standard, but yes, this is one of the tool in your armamentarium which you can use.
Yeah, Manjul, I just want to, one very short question. You didn't answer his question, what Eagle asked, but I think that's a very relevant point. It's a young child brain you are treating. And, if you have a hammer, everything looks like a nail. Colloid cyst, treating by gamma knife, I mean, I would be very, very surprised that that should be the way to go. Why would you do that? I mean, it's a surgery which is very simple surgery. Patient can be cured for life. Why you want to give radiation to a child with a colloid cyst?
Okay, sir. So for the colloid cyst, they have devised something called...
Let's you answer and then we conclude. Manas, okay, so conclude, just a minute. Answer to colloid cyst and then Dr. Manas.
I knew that this would create a controversy. And when we do this colloid cyst risk scoring, this was falling in the risk score group 2. So we offered that it could be a natural, even in the natural one, it could just remain static. We were encouraged to give it to the radiosurgery to this patient because of the literature evidence with some case reports which we could see. So we tried it. We offered it as a treatment option that yes, we can do it. We personally haven't done it. Yes, we did it. We did it with the literature evidence of some case reports and so just to know about it.
It's not, you're saying it's less invasive. It's not, it's the maximally invasive to the brain. I mean, you are giving radiation to the brain. How can it be less invasive? You're just not doing a cut. That's about it.
Okay, we will conclude the colloid cyst. Still debatable. A short comment from Dr. Manas.
I just wanted to answer Yegel about the radiation-induced malignancy, and this has been repeatedly shown in the literature that the risk is not 1 in the 1 million patients, especially if they are the syndromic ones. If they are, especially if they are the syndromic ones, the risk of malignant transformation is much high. I totally agree to that. But if they are the sporadic ones, then the risk is 1 in 1 million, which is not different from the general population.
1 in 1,000 to 1 in 10,000. That's the statistics quoted. The 1 in 1,000 to 1 in 10,000. I just reported, it's just coming out. Unfortunately, I do gamma knife. I do gamma knife for specific cases. We have just reported, it is coming out probably next week in ACTA, 1 non-syndromic vestibular sonoma, typical Kahan's criteria in ACTA. So it is gone to GBM. GBM. No, it's going to the sarcoma. One of the sarcoma is converted to. So, and the literature we reviewed. I know the data. Statistics. It's quoted between 1,000, 1 to 10,000.
But we have published 3 or 4 cases of radiation-induced glioma and meningioma. We have not operated millions of them. So I don't think go to that controversy. Manas?
The hemifacial spasm, did you do an EEG? Is it a seizure or it's a hemifacial spasm? The child you presented.
So EEG was normal in that patient actually. Normal. Even the video EEG was done and it turned out to be the normal.
Any pets,
and I was not sure whether
PET or PET was done?
No sir, PET was not done. PET was not done. But the MRS was done.
Thank you guys. We can continue on coffee.
Focal and it is corresponding to that because we have operated a similar case and we had done EEG and we had done a PET scan and we confirmed that then once we excised, the child was fine.
Yeah,
Thank you.
Yeah. Yes. Right. I was also 3 months.
Thank you, guys. Sure. Very thought-provoking. Thank you very much. Good session, good discussion. We can continue in coffee. Thank you. Eagle, do you have any instructions? Any housekeeping?
Well, yes. I mean, if we have a neurosurgery residence here, so we do a very short coffee break, and then you come to the first row here for discussion of some cases. But if there is no neurosurgery resident, so we will...
There is no resident out of 20 people.
If you have
no
Eagle, you have no resident, we can just have a little more discussion among the faculty. That's fine. We can have the
I
cases.
mean, we can fight between
we can
us.
fight.
That's okay.
Half an hour. Yeah.
So,
All right, gentlemen, thank you so much for sharing your knowledge on the session. That was one brilliant session from all of you. Now, may I please request Dr. A.K. Mahapatra, sir, to kindly be here on stage to felicitate our speakers, starting with Dr. Moni. We are having a small token of appreciation for you. All are same, sir. Dr. Shlomi. Dr. Manjul Tripathi. And may I please request Dr. Prafulla Kumar Sahu, as he is on stage, to kindly give away the memento to Dr. A.K. Mahapatra, sir. Thank you so much, all of you. Thank you. So we are, as we didn't do the breakout discussion, session 1. So we are doing it breakout discussion, session 1 and session 2 combiningly in the second floor, conference hall. And the session will be taken care by Dr. Eagle Shoshan. So everybody, after your coffee break, please join us the second floor, conference hall, as this space. Okay. We call it a day? Okay. 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 So, gentlemen, please proceed for the coffee break. And by 7 p.m., we are starting the inaugural session. So, please join us here. Thank you so much.
उनका लैपटॉप भी और तो होगा नहीं चार्जर भी दे दो अच्छी की किसी काम भाई पोडियम माइक ऑफ
Good evening, ladies and gentlemen. This side Anchor Tanvi, and I welcome you all to Asian Australian Society of Neurological Surgeon Education Course and Workshop. So, we really had a great morning session, very knowledgeable and very informative. And now it's time for the inaugural session. And to grace this occasion, we are really honored and privileged to have our chief guest, former State Commissioner for Persons with Disability, and our Honorable Mayor, Mrs. Sulochana Das, Organizing Chairman, Brigadier Professor Dr. P.K. Sahu, President AASNS, Dr. Eagle Soshan, Vice President AASNS, Dr. Basant Mishra, Guest of Honor, Dr. Thimapa Hegde, Organizing Secretary, Dr. A.K. Malik. May I please request to all the dignitaries to kindly have their seats on the dais. Please give them a huge round of applause, everyone. Our chief guest, former State Commissioner for Persons with Disabilities, Odisha, and our Honorable Mayor, Mrs. Sulochana Das, Organizing Chairman, Brigadier Professor Dr. P.K. Sahu, President AASNS, Dr. Eagle Soshan, Vice President AASNS, Dr. Basant Mishra, Guest of Honor.
I'm not Vice President, I'm Chairman WFNS Foundation. I was Vice President.
Guest of Honor, Dr. Thimapa Hegde, Organizing Secretary, Dr. A.K. Malik. I request everyone to kindly have their seats on the dais. Can I have a huge round of applause for our guests, please? Now I would request all the dignitaries to please come up on the dais for the lamp lighting. Let's remember Lord Ganesha for starting our event. And I request everyone to please stand for the lamp lighting.
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा ॐ गं गणपतये नमः ॐ गं गणपतये नमः गणपतये नमः ॐ गं गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया
गं गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः मङ्गलमूर्ति मोरया
ॐ गं गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया
ॐ गं गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक.
Thank you so much. Please have your seats. Now I would request our organizing chairman, Brigadier Professor Dr. P.K. Sahu, for the welcome address. Please give them a huge round of applause.
Namaskar. A very good evening, ladies and gentlemen. Greetings from Bhubaneswar for Asian Australian Society of Neurological Surgeons Education Course 2024. The first time the Asian Australian Society of Neurological Surgeon Education course being conducted in Odisha and Bhubaneswar. As organized chairman of AASNS 2024, I deem it a special privilege, immense pride, great pleasure to deliver a welcome address on this historic occasion of the inaugural function at the Mayfair Convention. Ladies and gentlemen, AASNS education course organized for the first time at Bhubaneswar, the city of temples. It is indeed a great honor, proud privilege, and pleasure for me to welcome Mrs. Sulochana Das, Mayor Bhubaneswar Municipal Corporation, the chief guest for the evening. She is not only a citizen, she is a mother, a wife, a journalist, former commission for persons with disability of state of Odisha, but also the present mayor of the Bhubaneswar. Bhubaneswar is the clean city, green city, sports city, smart city, and city of temples. With 500 temples, she always accorded topmost priority for prevention of disease by keeping the environment clean and hygienic. We are extremely grateful to you, madam, for accepting our request for the chief guest for this internal AASNS education course. You always accorded topmost priority for the care of the disabled. We are extremely grateful to you, ma'am, to have accepted our request for being the chief guest for this conference. We are all inspired by your gracious presence. A hearty welcome for this inaugural function. I welcome Professor Thimappa Hegde for accepting our request to be the guest of honor for the occasion. Dr. Thimappa Hegde is the director and senior consultant neurosurgeon at Narayan Hridayalaya at Bangalore. He has 40 years of experience in the work as an expert in different cities of India. He was a professor of neurosurgery at NIMHANS, Bangalore. He held the role of the past president of Neurospine Surgeons Association of India. He has authored about 40 scientific publications, leading medical journals, and has credited a book on history of neurosciences. His special interest has been stereotactic and functional neurosurgery, skull-based surgery, and active member of the Neurological Society of India, that is what we call NSI, the Indian Academy of Neurology, IN. On behalf of the organizing committee, I convey our grateful thanks to him. I assure the deliveration of this conference address the recent advance in neurosciences and emerging challenges and will contribute towards our healthcare delivery system more dynamic, responsive, and sensitive to the clientele of neurosciences. Ladies and gentlemen, I welcome the AASNS chairperson, Dr. Igal Shoshan, and Vice President, Dr. Basant Misra, and other entrance faculties like Dr. Kate Drummond, Vincent Ng, Dr. Raquel Grossman, Moni Winfilda, Shlomi Constantini, Bhadu Kuhar, and Manos Panigrahi, Dr. Girish Menon, national faculty like Dr. Brigadier Shashi Vadhanan, Dr. Deepak Agrawal, and Dr. Manjul Tripathi, and all the respected chairpersons and my dear delegates from all over India. I welcome all the delegates from Odisha, India, and abroad, all postgraduate students who have taken precious time out of their busy schedule to participate in the conference for the sublime purpose of dissemination of knowledge. As the dignitaries from the electronic and print media, the management staff of Mayfair Convention Lagoon, the pharmaceutical equipment instrument companies, Professor A.K. Malik, the Professor HOD Neurology at the SC Medical College, as the organizing secretary, has been a great help for organizing this conference. Bhubaneswar, the #1 smart city of India, welcome you all to this reputed hospitality. Its mouth-watering dishes, scenic beauties, ancient monuments, relics, and sculptures, and its evergreen and flourishing flora and fauna. Nevertheless, our spirits are high as ever, and we are not ready to give up on releasing the scientific enlightenment expected from a conference of such magnitude. Hence, this year, the entire conference has been arranged at Mayfair Convention. I hope all of us will have 2 days enthralling scientific sessions and will emerge wiser from the meeting. I again welcome all more than 150 delegates from across the world to this platform to acknowledge sharing and wish you good health and progress in life. I once again welcome you, ladies and gentlemen, for this AASNS 2024. Jai Hind, Jai Jagannath. Thank you.
Thank you so much, sir. It was lovely welcome address by our favorite Brigadier Professor Dr. P.K. Sahu, sir. And now I would request our organizing secretary, Dr. A.K. Malik, to speak some few lines. Please give them a huge round of applause.
A very warm good evening to all. So, ladies and gentlemen, esteemed colleagues and honored guests. So, this is the first time conference organized by Professor P.K. Sahu. So, I was a helping hand because I am busy in SC Medical College doing OPD. So, I reached here about half an hour before. Dr. Sahu has worked very hard to make this conference very successful. So, again, already Dr. Sahu has introduced the guests as well as the delegates. I again welcome all the delegates as well as the guests of this evening to this August auditorium. So, thank you again and welcome to Odisha for the 2 days conference. Let us hope the conference to be a mega success. Jai Jagannath.
Thank you so much, sir, for your valuable words. Now, I would request President ASNS, Dr. Eagle Soshan, to speak some few lines. Please give him a huge round of applause.
Thank you and good evening, everybody. Thanks for this honor that the mayor of the city is here with us. You know, I always respect people that were elected by the people. And he was elected by the people of Bhubaneswar to lead them and to create a better future for them. So I have a great respect to that. We are in the AASNS is basically the largest neurosurgical society that represent neurosurgeon in Asia, Australia, and Pacific, which is probably the largest one in the world in terms of, and we have our mission, among other mission, is to try to educate and to go from country to country and to serve as teachers and as trainers and to give some updates and to give some sometimes workshop on the field of neurosurgery. This is our work. We are very happy to be here. I would like to thank Professor Sahu, the local organizer, for all his efforts. Professor Basant Misra, who was the mind behind the idea of coming here to Bhubaneswar. He personally born in Bhubaneswar many years ago. And to thank all other faculties. And I wish us all continues fruitful meeting. The other hat that I have on my head is I'm an Israeli, and I'm also presenting my country when I'm here. And as you may know, Israel and India has a very good relationship, and in a line of that, we are here, we are proud to be Israelis in India and to develop the relationship, especially personal relationship with the people here, for the future of both countries. So thank you again for this wonderful opportunity. Thank you.
Thank you so much, sir, for the valuable words. Now I would request our guest of honor, Dr. Thimapa Hegde, to speak some few lines. I request everyone to please give all of the guests who are coming to give some speech, to give them a huge round of applause. Please, everyone.
one, please. Just put the next one. And full screen. Is the audio there? Just check.
Tvameva Mata च पिता त्वमेव त्वमेव बन्धुश्च सखा त्वमेव त्वमेव वीर्याद्रविणं त्वमेव त्वमेव सर्वं मम देवदेव
Tvameva Mata cha Pita Tvameva. This is a very common prayer that we make in India. Tvameva, you indeed are like my mother and father. When you say somebody is like my mother and father, that means it's someone other than my mother and father. Tvameva Bandhu. Bandhu is my close relative. Sakha Tvameva. You are like my close relative and my friend. Tvameva Vidya. You are my knowledge. Dravinam means my wealth. And finally, Tvameva Sarvam Mama Deva Deva. You are my everything. Now, who can fit into this definition? Somebody who's like my mother, father, but not my mother, father. A friend, a relative, my knowledge, my wisdom. In India, the highest regard is given to the Acharya, to the Guru. And I offer my very sincere regards to my teacher, Professor B.S. Das, who is from Orissa. And I had the great fortune of being with him throughout his tenure at NIMHANS. From the day he joined NIMHANS, I was there till he retired, and I was a great beneficiary to be his student. Today, I decided to speak on something about what is common to all of us. Many of us have come for this meeting. Some of us are organizing this meeting. There is something common to all of us, although we have come from different locations and we have different objectives in the same thing. And that is, we all want to be happy, isn't it? Why have we chosen to travel all this with the hope that this travel, this experience, taking off time from whatever I do, is going to give me more happiness than what I would not do. Perhaps even Professor Sahu is invited. I don't want to turn down his invitation. So that will give us more happiness. Normally, that is why in Sanskrit they say all our efforts are directed towards two things. One is called Sukha Prapti. That means this meeting should give me more happiness, or if I don't come for this meeting, I'm in serious trouble. That may be some of those who are working for this meeting. If you're not there, you're going to be in serious trouble. So you will see all our actions are directed either to Sukha Prapti or Dukkha Nivritti. Where do we look for happiness? We normally look for happiness in people, objects, and situations. Now, there is one problem when we look for happiness in people, objects, or situations. And what is that? It is invariably mixed with sorrow. Nobody can give you complete joy. There is always a feeling it could have been better. And even if this person or the situation is very good, we tend to be bound by it. Now, is there somewhere a solution to go beyond? And the solution is from looking for happiness to discovering happiness. Discovering happiness in everyday life. We are very busy all the time doing some activity or the other. What we need to now look is, it is not what we do, but how we do whatever we do. I'm speaking, you're listening. Can we just focus on what we are doing? Even as I'm speaking, our mind is processing information. The mind could be listening to what I'm speaking or what is happening in my own mind. The real discovery of happiness happens when we can be in whatever activity that we are doing 100%. Now let me take us, this is a trauma meeting. I thought I will just show, it comes a little odd, but here's a young fellow who came with a perforating injury. You can see a rod that has gone through the forehead. It came out in the occipital region. But the boy was conscious. He was moving all his limbs. He was able to speak. And because we could not position him well, the only way we had to do was to do a tracheostomy. This was how the imaging looked on the CT scan. This is how he came to us. Now, if you will see, this rod has gone exactly between the two carotids without damaging them, and it has grazed in such a way that it has missed the brainstem and it has come out in the occipital region without major damage to the CV junction. Removing the rod was not a big issue. This was the rod that came out. The bigger problem was the CSF leaks, the meningitis, and all the other problems. Fortunately for us, he came out well with a little scar on his forehead. Now, why I put this is, we see whenever we enter a trauma ward, especially in trauma or when people come with massive intracerebral hemorrhages, we see how devastating it could be. And the message for all of us is how blessed we are compared to what we see in our patients. Here is a little poem I want you to reflect on. I have never made a fortune and it's probably too late now, but I don't worry about that much. I'm happy anyhow. And as I go along life's ways, I'm reaping better than I sowed. I'm drinking from my saucer cause my cup has overflowed. Now, discovering happiness is through gratefulness. One question we need to ask: are happy people grateful? Happy people means those who are blessed with all the good things in the world. Are they likely to be grateful? Or is it the other way around? Or is it grateful people who are happy? And if you are discovering happiness, the answer is very simple. Whenever you are grateful, you are happy, because you cannot be grateful and miserable at the same time. Let me proceed by making a distinction between what is a luxury and what is a need. Sometimes we are exposed to unexpected luxury. Professor Sahu has put us up in one extraordinary hotel, and we've been to many luxury hotels, but this is really extraordinary. As you go, it is like a palace opening from one room to another. Now, what is a luxury and what is a need? A luxury is something, when you are exposed to it, you enjoy it. When it is not there, you can do without it. What is a need? A need is something without that you can't function. If my voice is not there, if my health is not there, if there is no power, if there is the projector is not working, now the meeting stops. A need is something without which you cannot function. But what is the distinction between the two? Normally, when it is there, what about a need is that when it is there, we take it for granted. When it is not there, we will see we cannot do without it. Now, if you're looking for discovery of happiness, the secret is converting my needs into luxury. That means I'm able to speak, I can think, I can breathe. You know, if you can count your blessings, this is what is called grateful living. Living every moment with a sense of gratefulness. Let me progress a little more. What is a gift? A gift is something that we value. A gift is something that has been given freely. And I have a question for you. What is that which we value, which is something of great value, and it is there all the time? Think. What is that which has been given to us freely, which is of tremendous value, and that is the gift of this moment? To be there 100% in body and mind, to be so sensitive to this moment. Now, in the pace of life that we go, what happens is we miss this moment because we are not there 100%. Somebody asked this question, are we in real time or are we in psychological time? Psychological time means I could be here, but my mind is somewhere else, and I have missed the gift of this moment. Now, what happens if I miss this moment? Of course, I have missed one moment, but then the teacher says, don't worry, you will get another moment, but can you live in that moment? So the real secret of being able to discover happiness is to be able to live in this moment, moment to moment. There is a nursery rhyme which goes like this: the time to be happy is now, the place to be happy is here. The way to be happy, the nursery rhyme says, to make someone happy. Don't try that because you will never succeed. So I have modified it. The way to be happy is just be happy. You've seen that Nike sign? Just be happy, and to create a heaven right here. I'll conclude with a few sessions, with a few suggestions of how to be able to discover happiness moment to moment, every moment. One of them is consciously slow down. Now, we may be very busy doing many things. We may be driving very fast. But whenever you are aware, you consciously slow down. And the rule is stop or slow down. Look means, even at this moment, be aware, not in your world of your thoughts. Your thoughts always take you, but in your world of senses, to be able to see, to be able to feel, to be able to touch. To look is to be in your senses, and to go means to be 100% in whatever you do. The next question is, what is that which takes away from the gift of this moment? And the answer is, whatever I give a lot of importance to, for example, if I give a lot of importance to my body, my family, my friends, my possession, my profession, whatever I give a lot of importance to, think and you will be able to answer it. That something can be the cause of all the problems in our life. And therefore, what is the solution? Give relative importance. Relative importance is, now the question is my destination important, or is my journey important, or is the process of going through the destination, going towards the destination is important? That means if I can work on each moment. At a certain stage of life, I would like you to dwell on this entity called PORT. It's an acronym. Less of possessions, less obligations, less relations, less transactions. Because if you're going to keep yourself busy all the time, it is possible that you may miss the glory of this moment, even after you have accomplished so much. Someone has rightly said, if you always do what you always did, you will always get what you always got. So look differently. In Hindi, there's a word which says, Dekho suno mat bolo, which means look, but avoid talking. Reduce talking to the others as much as possible. More importantly, avoid self-talk. Self-talk takes you away from the gift of this moment. Another thing is, we don't need to prove anything to anybody. Whenever there is an effort to prove something to somebody, it is the work of the ego. There was a man who was sent to a psychiatrist, and he was on the psychiatrist's couch. And he tells the doctor, I really do not know why I have been sent to you. I have a very good job, a very high-paying job, a wonderful boss who gives me all the freedom in my life. A very rare combination of a boss who pays you a lot but gives you so much freedom. A wonderful, loving spouse, excellent health, well-disciplined children. Suddenly the psychiatrist gets a little alarmed and comes to him and says, and since how long have you been in this condition? If you tell somebody you are happy, he will send you to a psychiatrist. On the other hand, if you tell somebody I have a problem, they'll say, halt, listen to me, this is nothing compared to what I have. I'll conclude by saying, what have I told you already? We are all seeking happiness. We seek happiness in people, situations, and objects. We see lots of limitations in them. Can we, instead of seeking happiness, look for discovering happiness through gratefulness, to be able to shift from seeing every need in my body. That means every moment as a luxury. And this is what is called grateful living. To be able to appreciate this moment as a gift. And finally, I'll leave it with 2 words. These words have enriched my life tremendously. And this was a Swedish economist, a Nobel Prize winner, a person of great inspiration to the former American President J.F. Kennedy. And he says, for all that has been, thank you. And for all that shall be, yes. Thank you very much.
Thank you so much, sir. This was very informative and inspiring for us. Now, I would request all the dignitaries to again please come up on the stage. So now I would request Dr. Kate Drummond to address the August gathering. Please give her a huge round of applause, please.
Thank you for the opportunity to speak. India holds a very special place in my heart. I first came to India, to Bangalore, in 1986 as a medical student and stayed here for 3 months and had the most wonderful time, and I've been back many times since and have many friends across the continent. This visit I managed to extend into a holiday, a vacation, so thus far I've been to Delhi, Jodhpur, Udaipur, Varanasi, now I'm in Bhubaneswar, and then I'm going off to Jaipur and then back to Bangalore to see my friends. So I've managed to turn it into a real wonderful vacation. But, of course, India is also a very valued member of the Asian Australasian Society of Neurological Surgeons, of which I'm the president. It's one of our largest members, of course, and a very active member, and through people like Professor Misra, we've always had a great, I've lost the word, we've also always had great input into the society from India. So it's wonderful to be here for this meeting. We're all very much enjoying the company, the hospitality, the venue, the scientific exchange, the food, especially, and so we're all very pleased to be here. So thank you very much for the organising committee, for the effort that everyone has put into it, and it's great to be in India, and we hope to be back. Thank you.
Thank you so much, ma'am. Now I would request Chairman, WFMS Foundation and past President, Aasns, Dr. Bashant Mishra, to address the August gathering. Please give him a huge round of applause.
Thank you. I'm actually the son of the soil. I was born here. I won't tell you when because you will know my age otherwise. But I left this city in 1975. But I come very often because my family is still here. And let me thank from the bottom of my hand for all the guests who have come all the way and to Bhubaneswar, the smart city. And I told them this is the first smart city of the country. And so I'm very proud of that. I also am very happy to have the mayor with us, who almost becomes a colleague of mine because she's a student of my father. So see, her subject is economics, and my father was an economics professor. So she told me that she has read his books. So that's some camaraderie there. Thank you very much for joining us. It's a pleasure to be here. And I thank all the delegates who have come here. This is one of the efforts of the Continental Society, of which Kate is the president currently, and Professor Soshan is the chairman of the education committee. As he said, we go to different parts of our continent to have interaction, learn from each other. I wish there are more young neurosurgeons come over here to share the knowledge so that we have a good time. Thank you very much, Professor Sao and the team. And Thimapa Aja, always a great friend of mine. Spectacular speech. Thank you very much. Appreciate it.
Thank you so much, sir, for the valuable words. Now I would request our Honorable Mayor, Mrs. Sulochana Das, to come up on the stage and release the book. First one we have the International Education Course Aasns 2024. The Souvenir Asian Australian Society of Neurological Surgeon Education Course 2024. I would request our Honorable Mayor, Mr. Sulochana Das, to release the book. Please give a huge round of applause, everyone. Huge round of applause, everyone. Now we have another book to release. Progress in Clinic Neuroscience Stereotactic Radiosurgery SRS for Brain and Spinal Disorders. I request everyone to give her a huge round of applause, please, everyone. Now I would request our Honorable Mayor, Mrs. Sulochana Das, to present the award, Professor B.S. Das oration given by Dr. Thimappa Hegde. Please give him a huge round of applause. We have the award to present by our Honorable Mayor, Mrs. Sulochana Das. I request everyone to give him a huge round of applause. Now I would request Brigadier Professor Dr. P.K. Sahu to present the Patachitra to Dr. Thimappa Hegde. The Patachitra is the sign of Orissa culture. Now I would request Dr. Eagle Soshan to present the memento to Dr. Thimappa Hegde. Please give him a huge round of applause. Thank you so much. Now I would request our Honorable Mayor, Mrs. Sulochana Das, to present the memento to Brigadier Professor Dr. P.K. Sahu. Please give him a huge round of applause. I would request Honorable Mayor Mrs. Sulochana Das to present the memento to Dr. A.K. Malik. Please give him a huge round of applause. Now I would request Honorable Mayor Mrs. Sulochana Das to present the memento to Dr. Eagle Shoshan. Now I would request our Honorable Mayor Mrs. Sulochana Das to present the memento to Dr. Kate Drummond. Now I would request Honorable Mayor Mrs. Sulochana Das to present the memento to Dr. Basant Mishra. Now I would request Brigadier Professor Dr. P.K. Sahu to present the memento to our Honorable Mayor Mrs. Sulochana Das. Now I would request our chief guest, Honorable Mayor Mrs. Sulochana Das, to address the August gathering. Please give her a huge round of applause, everyone.
Thank you so much. Good evening, ladies and gentlemen, honorable dignitaries on the dais, organizing chairman Aasns, Dr. P.K. Sahu, President Aasns, Dr. Weigel Sosan, Organizing Secretary Dr. A.K. Malik, Guest of Honor Dr. Thimampa Hegde, and Honorable Guest Dr. Basant Mishra, dignitaries present here, and medical students and all the delegations from medical fraternities. I welcome you all to this beautiful city. It's a great honor to be here. I'm really grateful for the invitation to this distinguished event. I would like to extend my sincere gratitude to the organizing committee, especially Dr. P.K. Sahu, for selecting Bhubaneswar as the venue of this great event. Thank you so much, sir. As you know, Bhubaneswar is famous for its vibrant culture and dynamic spirit, which stands as a beacon of health and sports excellence. Events like these not only enrich our city's profile, but also it will contribute significantly to its growth and development. With its unique blend of heritage and modernity, Bhubaneswar offers a perfect setting for intellectual exchange and exploration. I encourage all participants to take this opportunity to delve into our city's ancient temples, vibrant performing arts, and rich cultural heritages. Bhubaneswar is home to several major hospitals, that play a very crucial role in providing healthcare services to its citizens. Government institutions like Aasns, Capital Hospital, and Municipal Hospital, and many prominent private hospitals and medical colleges have strengthened healthcare infrastructures of our city. These hospitals offer a wide range of medical services, including specialized treatments, emergency cares, and preventive health programs. I would like to tell something about our government's performance here. Every life is precious. That has been the guiding principle of our Honorable Chief Minister Sri Naveen Patnaik. Under his able leadership, Odisha government has provided free healthcare services to almost 95% of its population through Biju Swasthya Kalyan Yojana, BSKY card, by integrating specialized fields like neurology into this framework. Bhubaneswar is not only enhancing its healthcare infrastructure but also prioritizing the well-being and medical needs of its population. Bhubaneswar's rapid growth is underscored by the development of diverse health infrastructures to meet the evolving needs of its residents. Your initiative to organize specialized fields such as neurology represents a commendable step forward in this trajectory. By focusing on these areas of healthcare like neurology, you are not only addressing the specific healthcare like neurology, you are also giving importance to the medical concerns and ensuring the residents that have access to comprehensive and specialized treatment options. In fact, when I was coming, I have interacted with the delegates from abroad. I think they are renowned neurologists, but whatever remark they have given about our city, it was really, I just can't explain it. I am really feeling proud that my city is so much clean and it's a very livable city. They liked it. I don't want anything more than that. Thank you so much for your appreciation and all these things, and I would like to request the organizers of this program to continue organizing such initiative in our state, and I wish the great grand success of this event, and I hope that this will be definitely a platform for exchanging ideas and new technologies which you have introduced in the case of neurosciences and medical sciences. Thank you so much. Vande Utkal Janani.
Thank you so much, ma'am, for being a part of this occasion, and you're really being inspiring to all the women present here, and you made this Bhubaneswar, the city, very beautiful, and we are really very proud of you, ma'am. Thank you so much. Now I would request Dr. Eagle Soshan to present the Patachitra to our chief guest, our Honorable Mayor, Mrs. Sulochana Das. It is the representation of Odisha art and culture. Okay, we'll present this after some time. Thank you so much, everyone. Please have your seats. Thank you so much. Now I would request Brigadier Professor Dr. P.K. Sahu to hand over the Lord Jagannatha to our Chief Guest, Honorable Mayor Mrs. Sulochana Das, the Lord of Universe, Lord Jagannath. Please give a huge round of applause. Okay, can we just hear a Jai Jagannath from you all? Once again, Jai Jagannath. Thank you so much. Now I'd request our Honorable Mayor Mrs. Sulochana Das to present the Patachitra to Professor Dr. Eagle Soshan. It is the representation of Odisha art and culture. Please give them a huge round of applause, everyone. Now I would request our Honorable Mayor Mrs. Sulochana Das to present the Patachitra to Professor Rachel Grossman. Now I would request our Honorable Mayor Mrs. Sulochana Das to present the Patachitra to Professor Craig Dumont. Now I would request our Honorable Mayor Mrs. Sulochana Das to present the Patachitra to Professor Vincent N.G. Now I would request our Brigadier Professor Dr. P.K. Sahu to present the Patachitra to Professor Girish Menon. Now I would request Brigadier Professor Dr. P.K. Sahu to present the Patachitra to Professor Slomi Constantini. Now I would request Honorable Mayor Mrs. Sulochana Das to present the Patachitra to Professor Moni Benifla. Now I would request Honorable Mayor Mrs. Sulochana Das to present the Patachitra to Chairman WFS Foundation, past President ASSNS, Dr. Basant Mishra. Now I would request our Honorable Mayor Mrs. Sulochana Das to present the Patachitra to Dr. Manas Panigrahi. Now I would request Honorable Mayor Mrs. Sulochana Das to present the Patachitra to Dr. Bhadu Kavar. Thank you so much, everyone. Please join for the photographs. Everyone, please join for the photograph. Thank you so much. Thank you so much, everyone. Please take your seats. Now we are having a special performance which represent the culture and the art of Odisha. Today the team will perform Chira Namasya, a Saint's tribute to Lord Jagannatha and our musical legend such as Bhikari Bala, Akshay Mahanti, Raghunath Panigrahi, Prafulla Kar and all. Their voice and the Odissi dance will mesmerize with Bhakti Bhava now. Let's remember our old tradition of Kirtan and let us experience now the new age Odissi dance in a Broadway presentation. Jai Jagannath, everyone. Jai Jagannath. Can I hear a Jai Jagannath? Ladies and gentlemen, let us welcome the Sashwat Joshi's team with a huge round of applause. Sashwat Joshi is an internationally acclaimed Odissi dancer and choreographer. He learned the Odissi under the able guidance of Padma Shri Kumkum Mahanti and Padma Shri Ileana Christie at Odissi Research Center and Art Vision. He has done his masters in Odissi dance and awarded with Sangeet Ratna with gold medal from Rabindra Bharati University. He has done his masters in English literature from Utkal University. He has done his special internship on Broadway at Seoul Institute of the Arts, South Korea. As he has done many international performances, and now we are very honored to have them on our stage. Please give them a huge round of applause. So ladies and gentlemen, let us welcome the first item. The team will perform Chira Namasya. Jai Jagannath.
मो श्रीमंदिर साखी मु सहस्र वर्ष इतिहासर ओडिया जातिर अस्मिता अहंकार जय आउ पराजयर मो भीतर शंखनाभिमंडल विराजमान ए जातिर प्राण बिंदु महाप्रभु श्री जगन्नाथ आउ बाहरे ए जातिर अपूर्व महिमा मंडित शोभा यात्रा मु देखिछि अनेक आरोहण ओ अवरोहण को मु देखिछि अनेक पराजयर पराभव को पुणी अंगे लिभेछि अनेक विजय उत्सव को एई दक्षिण द्वार साखी केते गजपति गारिमार श्रद्धा और समर्पण ए जाति आउता गजपति निजर सकल सुखर श्रेय देइचंती मोर पुरोधा महाप्रभु श्री जगन्नाथ को
उत्तिष्ठ श्री जगन्नाथ उत्तिष्ठ करुणानिधि उत्तिष्ठ सर्वलोकेश सुप्रभातम् अभूत विभो उत्तिष्ठ श्रीमनोनाथ ओंकार प्रणवात्मक केबे आनंद मुखर आनंद बजार केबे श्रीहीन सिंह दुआर केबे आनंद मुखर आनंद बजार केबे श्रीहीन सिंह दुआर लुहरे मु भिजिछि बहुबार बैरी दाउरे पुणी कांदिछि বহুবার অনেক আনন্দর অনেক আতঙ্কর অনেক উচ্ছ্বাসর অনেক ବିଶ୍ୱାସର ସାକ୍ଷୀ ହେଇ ରହିଛି ମୁଁ ଶ୍ରୀମନ୍ଦିର ଶ୍ରୀମନ୍ଦିର ଶ୍ରୀମନ୍ଦିର
एका तो भकत जीवन एका तो भकत जीवन भकत निमन्ते तोर शंख चक्रे चिन्ह शंख चक्रे चिन्ह एका तो भकत जीवन एका तो भकत जीवन भकत तो माता पिता भकत तो बंधु भकत हितरे तोर नाम कृपा सिंधु नाम कृपा सिंधु एका तो भकत जीवन एका तो भकत जीवन धेनु पछे पछे बछा गमे क्षीर लोभे भकत पछरे तू ही थाऊ से ही भावे थाऊ से ही भावे एका तो भकत जीवन एका तो भकत जीवन
आहे चकाखी हे चकाखी आहे चकाखी आहे चकाखी आहे चकाखी आहे चकाखी सुखिलाणी कंठ डाकी डाकी सुखिलाणी कंठ डाकी डाकी सत कहूची कि मिछ कहूची सत कहूची कि मिछ कहूची बाईसी पहाच तोर साक्षी आहे चकाखी आहे चकाखी आहे चकाखी आहे चकाखी दिने न शुणिलु दुख मोर तू किनु हना थर दिने न शुणिलु दुख मोर तू किनु हना थर बड़ आशा करी आसीथिली धाई बड़ आशा करी आसीथिली धाई बड़ दांड तोर अच्छी साथी आहे चकाकी आहे चकाकी आहे चकाकी आहे चकाकी
ଚାଲ ସଖୀ ଆମ୍ଭେ ଦର୍ଶନ କରିବା ଚାଲ ସଖୀ ଆମ୍ଭେ ଦର୍ଶନ କରିବା ନୀଳଗିରି କାଳିଆକୁ କେଉଁ ସୁରପତି ବେଶ କରିଅଛି ଗିରିବର ତୋଳିଆକୁ ସେ ଯେ ଶ୍ରୀମୁଖ ତୋରା सिरे सोना सोता केरा केरा से जे श्रीमुख तोरा श्वेत पद्म आखि देखिले गो सखी चित्त की बाहुड़े आऊ श्वेत पद्म आखि देखिले गो सखी चित्त की बाहुड़े आऊ कर्णरे कुंडल दिसे झल झल कौस्तुभ दाऊ दाऊ से जे हिया भूषाण मिशा मिशी बारा निधि फल से जे हिया भूषाण
चतुर्भुजो जगन्नाथ कंठशोभित कौस्तुभ पद्मनाभो वेदागर्भ चंद्र सूर्य विलोचना जगन्नाथो लोकनाथो नीलाधीश परोहरी दीनबन्धुर्दया सिन्धु कृपाळु जनरक्षक शम्भुपाणि चक्रपाणि पद्मनाभो नरोत्तमः जगतां पालको व्यापी सर्वव्यापी सुरेश्वरा लोकराजो देवराज चक्रभूपश्च भूपति लीलाद्रिपतिनाथश्च अनन्तः पुरुषोत्तमः ତାକୁ ଠାକୁର ସେ ସବୁଠି ଥାଏ ଅନ୍ୟମାନେ ରଖେ ତାକୁ ମାରିବ କିଏ ଆସୁରେ କଳା ପାହାଡ଼ ହଜାରେ ଥର ଥିବ ଏ ଶ୍ରୀମନ୍ଦିର ସିଂହ ଦୁଆର ଗୁରୁଥିବ ସେ ଅତୀତ ପାବନ ମହାନେତା ସିଏ ମୋ ଜଗନ୍ନାଥ ତା ବିନୁ ଶ୍ରୀହୀନ ସାରା ଜଗତ 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 जगन्नाथ जय जगन्नाथ जय बलदेवा जय सुभद्रा जय जगन्नाथ जय जगन्नाथ जय बलदेवा जय सुभद्रा जगन्नाथ जय जगन्नाथ जय जगन्नाथ जय जय जगन्नाथ जय जगन्नाथ जय जगन्नाथ जय जगन्नाथ जय जय जगन्नाथ 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 जय जय जगन्नाथ जय जगन्नाथ जय जगन्नाथ जय जगन्नाथ जय जय जगन्नाथ जय जगन्नाथ जय जगन्नाथ जय जगन्नाथ जय जय जगन्नाथ जय जगन्नाथ जय जगन्नाथ जय जगन्नाथ जय जय जगन्नाथ जय जगन्नाथ जय जगन्नाथ जय जगन्नाथ जय जय जगन्नाथ जय जगन्नाथ जय जगन्नाथ जय जगन्नाथ जय जय जगन्नाथ
Okay, this was the first performance, and here we go for the second one, the Kathak dance. This is a dying art form from the district of Ganjam. Ranapa is the most famous dance of the southern state of Orissa, which is the part of culture. Ranapa literally means a stilt. This dance form is famous for Ganjam district, Orissa. It is performed on the street and accompanies by drum music along with songs related to Lord Krishna childhood stories. Let's watch our wonderful team from Ganjam, Chhatrapur, led by Sudhanshu Shekhar Satpathy. Give them a huge round of applause, everyone. Now we'll go for the third presentation, Dhemsa. Dhemsa is a traditional folk dance of tribal people of central India, southern Orissa and adjacent areas of Chhattisgarh and Andhra Pradesh. Today our team Koraput will perform Dhemsa. The dancers form a chain by holding each other by the shoulder and waist, then dancing to the rhythm of traditional instruments. Dhemsa is performed in groups. Its interest comes from its distinct style of composition, rhythm, body language, traditional costumes, hairstyles, and choreography. The team Lashyakala Koraput will present now Dhemsa dance, tribute to the tribal people of the state.
ये चैत परब बड़ बेट मजा ये परा सरदा नाई ये टकी राशि सांगे पिला मादा देखा धेमुसा करिबा पाई ये मोरा दादा ले फुक टोकी दिया मोइरा दादा रे टोकी राशि के नाच नाचाइबी टोकी दिया मोइरा दादा रे टोकी राशि के नाच नाचाइबी ए चैत पर्व गीत मारी मारी डांडे जाई ठिया हेबी ए चैत पर्व गीत मारी मारी डांडे जाई ठिया हेबी टोकी दिया मोइरा दादा रे टोकी राशि के नाच नाचाइबी टोकी दिया मोइरा दादा रे टोकी राशि के नाच नाचाइबी ए चैत पर्व गीत मारी मारी डांडे जाई ठिया हेबी ए चैत पर्व गीत मारी मारी डांडे जाई ठिया हेबी टोकी दिया मोइरा दादा रे टोकी राशि के नाच नाचाइबी टोकी दिया मोइरा दादा रे टोकी राशि के नाच नाचाइबी बरसा बड़े बरसा ननी छेली माई मला सीते एक दमाली सेली माई मला सीते हराई नेबी की जिताई नेबी देखा चैत परब गीते के सुरबाली चैत परब गीते
दमाली बबिया गाली कट पाड़ी तुई नाची दिली केंताई भी घर जुआई की छाड़ी काय को दमाली घर जुआई की छाड़ी
ए गीत मारी मारी नाच भी आवरी सबके नाचाइबी ए गीत मारी मारी नाच भी आवरी सबके नाचाइबी टोकी दिया मोइरा दादा रे टोकी राशि के नाच नाचाइबी टोकी दिया मोइरा दादा रे टोकी राशि के नाच नाचाइबी দিয়া লদল দিয়া ননি টিপে ফুটাইলা কিয়া কাইসুর বালি টিপে ফুটাইলা কিয়া তোমার বিবা বেলে খবর দিয়া মলি ফুটাইয়ান বুজনালিয়া এ বুটকি জনা ফুটাইয়ান বুজনালিয়া
লসম ধরিলা কসম খাই বাবু অস কোড়ি গালি বলে কাই কদমালি অস কোড়ি গালি বলে তব কোড়ি পাঁজি পাতাই দেবুনু না মাঙ্গিনি আই বাদিন কাই কদমালি মাঙ্গিনি আই বাদিনি
এ মজুর বুটা ধরি করি ছানে বাট কারাইবি তিতিরিতি ফুকরে ময়রা আটা হালাইবি
ফুকি দিয়া ময়রা দাদা রে পিলা নাচিকে নাচ নচাইবি ফুকি দিয়া ময়রা দাদা রে পিলা নাচিকে নাচ নচাইবি
এ চৈত পর্ব গীত মারি মারি ডাঁডে যাই ঠিয়া হেবি এ চৈত পর্ব গীত মারি মারি ডাঁডে যাই ঠিয়া হেবি
ফুকি দিয়া ময়রা দাদা রে পিলা নাচিকে নাচ নচাইবি ফুকি দিয়া ময়রা দাদা রে পিলা নাচিকে নাচ নচাইবি ফুকি দিয়া ময়রা দাদা রে পিলা নাচিকে নাচ নচাইবি ফুকি দিয়া ময়রা দাদা রে পিলা নাচিকে নাচ নচাইবি ফুকি দিয়া ময়রা দাদা রে পিলা নাচিকে নাচ নচাইবি ফুকি দিয়া ময়রা দাদা রে পিলা নাচিকে নাচ নচাইবি ফুকি দিয়া ময়রা দাদা রে পিলা নাচিকে নাচ নচাইবি
And the fourth presentation is Sambalpur is the fifth largest city in the Indian state of Orissa. It is located on the banks of river Mahanadi. It is the home of the Sambalpuri sari and weavers. Our Sambalpuri dance is famous worldwide, our Rangapati dance, and our Maila Jada is very rhythmic and created history, and today we have Sashwat Joshi who danced in front of Patti Eiffel Tower, and we got huge recognition. Respectively, it has been performed in front of all iconic towers worldwide, and Prime Minister Shri Narendra Modi too tweeted Mr. Joshi contribution. Prime Minister UK Rishi Sunak also tweeted about Mr. Joshi and praised his performance when he danced in front of Trafalgar Square. Let's welcome them on the stage now. Let's feel the vibration and let's dance with them.
Namaskar, good evening everyone. You're all there. You're all watching or busy. Shall we continue to dance? I can't hear. Shall we? Shall we continue to dance? Oh great, performance is there. So there are artists all the way coming from different part of the Odisha, and I hope you will enjoy this beautiful folk number. And I must say that you will be amazed with this dance form. And this is the last piece of dance. And let's dance and let's feel the rhythm of Western Odisha, and let's do Sambalpuri dance here.
ननी तोर मुल की हंसी पागल कला तते जे देखला गोरे से तो मला ननी तोर मुल की हंसी पागल कला तते जे देखला गोरे से तो मला
ভাল পায়ে মেঘাতে খালি নিজের কবি করি রাখনি তাতে মোর খানি রাজা পানি করি সজে মোর রাজা হিরো রানী তোর লাগে বাবু হচ্ছে বলি হায় রে মোর রাজা পিয়া তোর লাগে যে মতে ভুলি
तोर मुल मुल के हंसी देखी रसीता गली तोर सुंदर चेहरा देखी मुही पागला हेली हाय रे मुरानी गोरी मझला डाली किते चलू छु अटा के हले हाय रे मोर सुंदरी मते काजला डाली किते देखो छु आखी खुली खुली आमे समलपुरिया चुमको चुमा मलका आटा तेरी आँखी कहेसी कथा पाए झर चम चम लागसी महानी आठा राजा आमर बजा आए गुंडुली बजा किंदरी नाचले लागसी मजा ओहरी जासु ममरे हे प्रभु नाचिया हमें तो समझुरिया मोटा हमर सपना केनु पाबो हमर लेखरे खुशी मिलन सब संगे रे केते सुंदर हमर दुनिया 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 हमें समलपुरिया हमें समलपुरिया हमें
Well, actually there is a different feeling when you dance Sambalpuri dance. Either there is audience or there is no audience. But I really feel that the class people, whoever are all here, they must be enjoying a lot, especially madam. when Sambalpuri beat starts, we all dance because this is a beauty of our own culture, and a country grow where culture is praised everywhere from their heart. So this is India. This is incredible India, I must say. And being a brand ambassador of Incredible India, my salute to all our delegates coming all the way from different part of the country. And I must thank Dr. Sahu, who has conducted this amazing conference so well. But I'm deeply touched with the presence of all the delegates from everywhere. But I want to say, share maybe very small word that without Rangavati, the event is finished. No, right? We can't complete without Rangavati. Guys and girls and gentlemen, ladies, shall we do Rangavati? Shall we do Rangavati? But then we all have to dance. Are you ready to dance? Are you ready to dance? Yes. So well, let's do Rangavati and let's cheer up. Let's listen some sound. Rangavati. Yes, let's do Rangavati and let's feel the vibration of Odisha and let's feel the amazingness of Odisha because Odisha is India's best kept secret, and we believe Atithi Deva Bhava. We believe that our guests they are our God, and we feel that you all the guests, you are all our God, coming all the way from different part of the world. And before I start, I must say that this is incredible India and this is incredible Odisha. The scenic, serene, sublime is in Odisha, and you must visit Konark Temple, Sun Temple of Odisha, and if you get time, do the parikrama of Lord Jagannath, and you will really blessed with Lord Jagannath's blessing. Let's do Rangavati. Ready to dance? Yes, let's do Rangavati. Tanvi, ready?
पानी मरेंगे बेचारे। होती रंगवती रंगवती तू जो न होती प्राणों में शक्ति न होती
Well, this is the power of Rangabati. Jai Ho Rangabati ki! Well, I would like to request our all delegates coming from all the way from Australia and different part of the country, so world, please come and let's dance, sir. This is the most memorable moment we can cherish. I know you all are great in your profession, but you are in Odisha, and let's give a tribute to beautiful land of Odisha. All the delegates coming all the way from different part of the world, I would like to request them, and let's move with Rangavati. Sir, can I have you all? Yes, please. Yes, please, sir. Yes, sir. Yes, sir. Yes, sir. Can we have the Rangavati track once again, please? Yes, all are ready to dance? Yes, this is the energy.
पहले एक दिन वाले
Well, this was the power of Rangabati. Sir, how was it? Rangabati rocks! Yes, thank you so much. I would like to request Mr. P.K. Sahu, sir, and Dr. Sahu, please, if you are around, please come to the dais. If you are around, please, it's a humble request to come to the stage. And before we wind up, let me introduce all my dancer. And he's Anshuman Mahapatra, Gitanjali Mahapatra, Diksha Naidu, Sagarika Mohanty, and everyone knows him, so I don't need to introduce him. Well, Sonal Acharya, Swagatika Patri, Rajalakshmi Behra, Rajashri Shamal, and Shikruti Patnaik. And here are all the tallest dancers of the world. Anil Behra, Sita Ratnam. It's very difficult to wear this and dance. It's really, really difficult. This is one of the dying art form which we try to keep with us so that the artist will not die and the art will not die. This is one of the, I think we are really keeping this art form high so that everybody can watch and enjoy the dance form. This is Sudhanshu Sekhar Satpathy, and he is Chandra Shekhar and Akanksha Sahu. And our team leader, of course, Radha, I think she's there. Please come, Radha. And our PR team head, Sai Jyoti, please come to the stage. And here is myself, Saswat Joshi. And I must say, thanks to Dr. Sahu, sir, being so devoted, disciplined, determined, and dedicated. You made this happen, sir. And everybody in the whole history of Odisha, everybody, all the delegates dance Rangavati. All credit goes to you. Big round of applause to sir. Thank you, sir.
And it's a very great occasion, I must say. When I was told that Saswat Joshi will coming, so I was surprised, but who is Saswat Joshi? He said, no, you have to see. And he's not only popular in Odisha, India, abroad, wherever you have seen, he's most popular, and they do extremely good performance. And I really appreciate, it has been very nice. All the people, they have enjoyed your performance, and definitely, not only will go abroad, कभी मून में जो उड़ीसा वाला जाते हैं इसमें कभी चला जाएगा उधर भी प्रोग्राम होते विल डू इट हाँ जहाँ भी हो रंगवती का हर जगह में होगा इट्स अ वेरी गुड डांस एंड यू परफॉर्मड एक्सट्रीमली ऑल ऑफ योर स्टाफ दे हैव डन एक्सट्रीमली वेल एंड मेनी मेनी थैंक्स टू ऑल ऑफ यू मेनी थैंक्स थैंक यू वेरी मच एक्सीलेंट परफॉर्मेंस थैंक यू
Sir, my heartfelt thanks to you and the whole entire team. But I would like to say just one line that I am from a very traditional family of Odisha and from a very rural belt of Odisha. I'm from Titlagarh, and my father has never seen, last 25 years, my father has never seen my performance. But today, my father is there. He came today and he's there. He's watching my performance. So it is, I think, this is one of the most biggest achievement of my day, I believe, because every day either I am in Paris, I am in South Korea, I am in Japan, I am in some places in London or somewhere, but they always watch me through YouTube or social media. But today I am very happy. I think thanks to Dr. Sahu that he has put this, and today it is his marriage anniversary, and happy marriage anniversary, my father, my mother, and he is here today, and I'm really feeling blessed that he has watched my performance today, and with all dignity and with all honor, I'm giving my heartfelt thanks to my parents that they had decided that his son would be a dancer. I think this is the biggest achievement. My father and mother has blessed me, and with that confidence I'm continuing. He had a broken leg, and he has today just he opened. He has a lot of pain in his leg, but still he's coming. So it's really a biggest achievement of the event. I believe that today is my father is watching my performance, and I'm feeling blessed. Yes, if he can come to the stage. He was a school teacher, and like normal family, and as we are traditional Brahmin family, you must know in Odisha from a rural belt, and he was a school teacher, and he also wanted that either his son would be a doctor or an engineer. No offense to doctor, but he wanted that his son would be a doctor or an engineer. But when he understood that his son is a dancer, he allowed me and said, go and achieve your dream. I think every father should do that and allow their children whatever they want to do. Today I travel almost 70, 80 countries. I perform all over the world. But my biggest day is today, because on his marriage anniversary and on his presence, I could able to perform today. And I think this is the biggest blessing of me. And thank you, Dr. Sahu. Thank you, sir. Thank you so much and that you had invited us, and it is a blessing for me. Thanks a lot. Thank you, everyone. And thank you, my... Yeah, I would like to request him to speak something.
उपस्थित समस्त को मोर आंतरिक शुभेच्छा अभिनंदन नमस्कार जहाँ भी आज मु भाग्यवान आज ये भाया महफिल रे आपण मन सहित संग करी मोर निजर गोटे बोली पुओ मु भावुली प्रकृति रे से डॉक्टर की इंजीनियर हो बोलिकी किंतु डॉक्टर इंजीनियर मोर सहित सामिल होकर निजे मु आज धन्य मन करुच्ची भगवान तथा आपण आशीर्वाद थाऊ से एपरी उत्तर उत्तर वृद्धि हुई आपण तथा परिवेश समस्त मंगल करू जय जगन्नाथ
Thanks a lot, and you all, this mahol is very emotional now, but remember Rangavati and go back home so that the hangover should be there. Thank you, Tanvi. You hosted really beautifully, and thanks the whole team. Thanks to Sir Bhai for introducing me with Dr. Sahu and Dr. Malik, of course. And I'm very, very happy and honored today. Thanks a lot. Thank you so much once again.
Thank you so much. Thank you so much, everyone. Thank you so much, Asha Joshi and his team. You're really amazing. And thank you so much, everyone. This was really amazing, and I really loved hosting here. Thank you so much, everyone, for your valuable time. This is your host, Anchor Tanvi, signing off. So see you